Good morning, everybody. I, Ms. Sandhya Das, Director of Medical Affairs Foresight, extend a warm welcome to all of you on the second day of Envision 2020. Envision 2020 has given us the privilege to be academically associated with some of the best minds in ophthalmology, and this would not have been possible without the mentorship of Dr. Lalit Verma and collaboration with AIOS. We sincerely thank Dr. Lalit Verma for this. Though we cannot see you in person this time, Envision 2020 isn't just another virtual conference. It's a whole new experience built to support you and help you grow in this world that is ever changing. The first day of the conference was highly stimulating, with meaningful discussion revolving around topics pertaining to retina subspecialty and cataract and refractive surgery. Today also, we are conducting parallel sessions in Hall A revolving around glaucoma and infection control topics in Hall B. We at Cipla Foresight have leadership position in glaucoma, and we have pioneered and introduced the life-changing treatment, the topical carbonic anhydrase inhibitor, dorzolamide and dorzolamide timolol in India. In Hall A, the session will focus on practical pearls on managing glaucoma. The session will involve case-based discussion and will provide tricks and tips on how to manage the difficult cases. I believe this will serve as a knowledge feast for all of us. Not taking much time, I hereby wish to introduce the chairperson, Dr. G. Chandrasekhar, who will spearhead this session. Dr. G. Chandrasekhar, sir, has been associated with L.V. Prasad Eye Institute since its inception in 1987 and is currently the Vice Chair of LVPI. Dr. GC, as is popularly known, is an astute clinician and a passionate teacher. Dr. GC has trained over 43 glaucoma fellows, including 7 international fellows, and have published over 100 papers in national and international peer-reviewed journals, and is also been a reviewer for a number of ophthalmology journals. He holds the position of clinical professor at the University of Rochester and has become a visiting professor at the University of California. He is currently on the board of the World Glaucoma Association. I hereby welcome you, sir, to start with the session. Thank you.
Sandhya, we can't hear you.
Yes, sir. We're just looking in the technical team. Can you help, please?
Yeah, I think Dr. Chandrasekhar actually requires no introduction whatsoever.
Yes, sir. You can take it over, sir.
Yeah, and I think he's one of the finest persons that we have trained under, and everybody in he's been the ex-president of the Glaucoma Society of India, and he's one of the pioneers who comes out all the time with newer things. As a matter of fact, when we have the most difficult cases, he's the person to whom we refer our cases. But the biggest thing is that I always thought that I am a great person to deal with the patients. But every patient I send to him comes back and says, Dr. Harsh, you have to go to Dr. Chandrasekhar to learn how to deal with a patient. This is how wonderfully he treats his patients. And obviously for all the doctors, he's an icon. I think he's a wonderful human being, and he's been supportive to all of us all throughout our journeys. We will go ahead, and he's the vice chair at LVPI. Everybody knows him. So we'll hand over the mic to him to go ahead with further introductions.
Thank you, Harsh, for the kind words. I don't know how much of that I deserve. But anyway, we'll move on with the time, with the program as in the interest of time. And my job next is to introduce Harsh and Sachin, the moderators for this session. Before I do that, I would like to thank Lalit and All India Ophthalmic Society for creating this opportunity and to CIPLA for facilitating all this activity. I think between industry and academia, it's always a win-win situation. We need their help and they need our help. So thanks to CIPLA for this initiative. So I won't read what is there in the slide, but to say two sentences about Harsh, his name to fame is the laser procedures that he has innovated, and the Padma Shri, probably the only one to have that award among the glaucoma specialists. But I think, as he was saying, we have shared some patients together. And what comes out to me, the most important aspect of Harsh is that how patient-centric he is and how involved he becomes with his patients. I think ultimately we all have to survive because of the trust that we have of our patients, and building that trust, I think, what is important. And Harsh has gone a long way in doing that. Thanks, Harsh, for being there for all your patients and for co-managing some patients with me. If we can change this slide, we'll move on to Satyan. Sachin has an immense experience in glaucoma, having led the glaucoma division at Coimbatore Arvind Eye Hospital for 20 years. And he has moved on and started his own setup. Very innovative person, tech savvy, huge experience with the number of cataract and glaucoma surgeries that he has done. But I think what impresses me most about Sachin is that his clear thinking and his innovative mind and the way he presents at various meetings. I've not personally seen his surgery, but with looking at the kind of presentations he makes, I'm sure he's a great surgeon and a great clinician, and we'll have a lot to learn from Satyan. So with those introductions, I will probably hand over to Satyan now for introducing the panelists. Over to you, Satyan.
Thank you so much, sir, for the introduction. We'll go to I would like to introduce the other panelists for today's session. Good morning to all of you. May I have the slides, please? Today we have the experienced panelists today. Dr. Rita Damankar from Mumbai. All of you know Dr. Rita Damankar is from Lakshmi Eye Hospital. She is the Chief Medical Officer, and she has received many awards starting from her post-graduation days. There are many awards to her, but I'm not going to talk about all the awards here. And she's been one of the speakers in the national and international podiums. And to say specifically, she's one of the first ophthalmologists to start the selective laser trabeculoplasty in India. Then next panelist, please. I'll just give a very short introduction to each panelist. We have Dr. Sumit Chowdhury. He is a medical director, Eye Care and Research Center, senior glaucoma consultant at the Disha Eye Hospitals in Kolkata. He is one of the doctors who was mainly involved in the organizing many conferences with the GSI at Kolkata and also the Kolkata Academy of Ophthalmology. He has conducted numerous live surgeries and inspection courses. And of course, he's also been awarded with many papers in the glaucoma, in the East India Journal of Ophthalmology. Next panelist, please. We have Dr. Mayuri Kamar from Ahmedabad. She is the glaucoma consultant at Ocular Eye Center. And of course, she has a wide experience in over 30 years. She has been at RAO, and she has been with other centers as well in Gujarat. Now she is heading the glaucoma department in the Ocular Eye Care Center. One of her videos is mainly on the trabeculectomy. The animated video is one of the wonderful things that she has done. And she has a wide experience in glaucoma, vast experience in glaucoma. Thank you. Next one. Next panelist, please. Young minds. Dr. Sirish Nelvegi is from Bangalore. He's a director of Nelvegi Eye Hospital and Surgical Center. He has performed many glaucoma surgeries, like over 4,000 glaucoma surgeries. but he is not only the glaucoma surgeon, he has done refractive surgeries as well, like LASIK, ICL implantations, etc. And also he's been a regularly invited faculty in many of the national and the international conferences. And also he has been publishing many articles and also the books chapters. So with this very short introduction, I know that each panelist needs more introduction, but with the time, we will move on to the next session.
Thank you, Satyan. I think we'll take over now and start with Dr. Murli. By the time he picks up, can you just, Pooja, can you put Murli's slide? Because like we'll just have a short introduction.
Yes.
And Dr. Murli is the director of Swami Eye Clinic, but he's such a wonderful and a humble human being. I've seen so many of his surgeries. He performs all kind of complicated surgeries, and he has a number of publications. He's been such a good teacher all over. But what today we want to learn from his, and he has been speaking about the ocular blood flow. So Murli, please be kind enough to tell us in 15 minutes, what do you feel that how we can use and how the people listening to you can use ocular blood flow to help their glaucoma patients. Dr. Murli, can you put your slides please now?
Thank you, Dr. Harsh. And good morning to everyone. And I think all our esteemed panelists as well as faculty and the audience as well. And thanks to CIPLA for this kind invitation. And of course, Dr. Lalit Verma, who's been behind this wonderful program. I'm going to speak on the significance of ocular blood flow in glaucoma and how do we test it and how do we actually use this technology to look at managing our glaucoma patients. We all understand that there are a lot of non-IOP risk factors for glaucoma. Glaucoma being multifactorial disease involving several elements and not just intraocular pressure fluctuations, the gender, race, family history, some genetics, myopia, corneal thickness, so many factors to take into account when you're going to manage glaucoma. And of course, the vascular factors, vascular diseases like diabetes mellitus, migraine, hypotension, be it due to the drugs used for treatment of hypertension and so on. And of course, as a net result, the low ocular perfusion pressure. All of this has to be kept in mind in any individual patient you're dealing with when you manage glaucoma. First, a word about the ocular perfusion pressure in glaucoma. A lot of published literature, so I'm not going to go into each of these studies and describe what they have done. Just in brief, that the ocular perfusion pressure does seem to be important in certain subsets of glaucoma, where the intraocular pressure is not so important. The systolic perfusion pressure lower than 125 and a diastolic perfusion pressure of less than 30 has been shown to have a high risk of both glaucoma and increasing the risk of progression in these subset of certain patients where the perfusion pressure becomes important. Ocular blood flow deficits have been noted in glaucoma, retrobulbar, retinal, optic nerve head, and in the choroid as well. So various technologies have evolved to look at the circulation behind the eye, the retrobulbar vessels, the retina, and the choroid, looking at mainly the choroid. So many technologies like color Doppler imaging, retinal oximetry, pulsatile ocular blood flow, interferometry, Doppler FD OCTs, and CSLO, so many technologies. And most of these technologies have not really come into clinical practice. And most of us don't use it in routine clinical practice. But however, a few of these technologies like color Doppler imaging and now the OCT angio has just come in. And these are the technologies which some of us use to look at the retrobulbar circulation, the retinal circulation, and make some sense out of these technologies. I'll talk briefly first about the color Doppler imaging, and which I have been using extensively over the last few years to look at the retrobulbar flow. Color Doppler imaging actually measures the flow velocity in retrobulbar blood vessels, and the outcome parameters include the peak systolic velocity, the end diastolic velocity, the flow velocities, as well as the calculated vascular resistance index called the RI, which is the formula which is used to calculate the RI. And the color Doppler imaging is performed by technique which evaluates the erythrocyte velocity in large ophthalmic vessels such as the ophthalmic artery, the ciliary vessels. And this ultrasonic technique actually combines B-wave imaging with color Doppler, which looks at the movement of blood flow based on Doppler frequency shift. Compared to the other techniques, CDI has certain advantages, being non-invasive, does not require contrast medium, and once more, it is not influenced by poor ocular media like cataract or dense opacities. And there is no radiation involved, so it's relatively safe and convenient, and has been in use in ophthalmology for more than 2 decades. And I'll show you a short video clip of how this was done. We have actually worked with This can be done both in the supine as well as in the sitting position, depending on the experience of the radiologist who's doing the test. And this particular mode done by our radiologist at our associated center is done in the supine position. It requires a lot of practice and skill, and it's best done by a radiologist because these machines cannot be used by ophthalmologists because of the PC&DT Act. So therefore, you need a qualified radiologist who's adept at doing this kind of things. And the amount of pressure which you apply, the amount of
this will be scanning back onto the ophthalmic artery. This is his ophthalmic artery. That's good. So from here, I will make my way up, and I'm going to try to go to the central retinal artery.
Yeah, I'm going to show you a few examples of the studies which we had done with radiologist Professor Venkat Sai at the Bharat Scans in Chennai, as well as all of us who were trained with Professor Harris when he came to Chennai and taught us how to do the exact technique. These are some examples of color Doppler imaging used to look at normal PSV and EDV and the RI of the various vessels involved in the retrobulbar circulation. These are examples of abnormal CDIs of reduced diastolic flow, sharp peak velocities with sudden falls, loss of biphasic pattern, a lot of examples of abnormal scans. And this is how the report looks like, the findings from the ophthalmic artery, the CRA, the posterior ciliary vessels, temporal and nasal, as well as the measurements which you're actually seeing on the report. And we did compile the normative data based on the color Doppler imaging, looking at different age groups, and this is the mean of the ophthalmic artery, PSV, EDV, and RI for the CRA also, and the posterior ciliary artery. We also looked at the ocular perfusion pressure, the resistive index in relation to the intraocular pressure. All these were normal patients without glaucoma. So how do you interpret CDI? It's the velocity is absent. You can think of vaso-occlusive disease. If it is increased PSV, you can look at narrow vessels at the measurement site. Resistive index is a close correlation with the downstream vascular resistance. There's a reversal of flow. You can think of a severe stenosis and ocular ischemia, like that example which Professor Harris was trying to demonstrate. A meta-analysis actually showed us that the PSV and EDV decreased in OA, the ophthalmic artery, the central retinal artery, the posterior ciliary vessels, and the RA increased in central retinal artery and the temporal posterior ciliary vessels in normal tension glaucoma patients. So this is where it stands today. The color Doppler imaging test cannot be interpreted as flow values unless the diameter of the vessel is also measured. So the technology is now looking at the diameter of the vessels. Therefore, you can start looking at the blood flow vessels maybe in the near future. The CDI measurements depend on the probe position and the Doppler angle, as Professor Venkat Sai was pointing out in this video. The long ciliary artery can sometimes be mistaken for the short posterior ciliary vessels. It is quite difficult to image the short posterior ciliary vessels, but with some experience, like our radiologist, he easily picks it up almost in one shot. The reproducibility of the CDI parameters among different parameters can be really different and is acceptable for certain larger vessels or parameters, but not quite good for the others. So you do need a skilled radiologist, and you do need the same technique and the same position, and make sure the patient is comfortable and there's no pressure on the eye when the CDI is being measured. A word about the OCT angio, which is a new kid on the block, and I think that the technology has evolved to the present time, which we do have good machines which give us a lot of information about the OCT angio. What is OCT angio? It's a relatively new, non-invasive, dye-free imaging modality which provides both a qualitative and a quantitative assessment of the vasculature of the retina and maybe the optic nerve head. It also enables visualization of the choriocapillaris in areas of peripapillary atrophy. With OCT angio, the movement of the red cells is used as a contrast to delineate blood vessels from static tissues. And the features seen with OCT in eyes with glaucoma are reduction in the superficial vessel density in the peripapillary and macular areas, and complete loss of choriocapillaris in localized areas of the peripapillary atrophy, the so-called deep layer microvascular dropouts. These OCT angio changes correlate well with the functional changes seen on visual fields and structural changes seen on OCT, and I'll show you a few examples. The parameters which we get, as I mentioned, the vascular density of the optic nerve head, the flow index of the optic disc, the vascular density of the peripapillary retina, the capillaries, the vascular density in the macula, and this is said to correlate with the findings of patients showing the structural damage in fields as well as on OCT. The normal OCT angio, the NFAS projection resolved OCT angiograms of 4 plexuses seen in the right eye of a normal human, shows you the NLFP, the nerve fiber layer plexus, the ganglion cell plexus, the intermediate plexus, and a deep plexus. The NLF, the nerve fiber layer, and the GCLP can be combined into the superficial vascular complex, whereas the ICP and the DCP can be combined with the deep vascular complex, which is primary capillary networks. This is how the technology works. And this is an example of the SVC angiogram showing you a 6 mm square superficial vascular plexus complex, and shows you the defect both in the GCC as well as the corresponding change in the vascular pattern. So you do need to look at a 6x6 pattern of the GCC as well as the SVC angiogram, because a smaller 3x3 or a 4x4 may miss the common patterns of damage in glaucoma. This is an example of a normal angio disc. This is from the angioplex. And if you look at the angio view of the disc, and looking at the RPC, which is the radial peripapillary capillary vessel density, and this is the normal. And this is showing you the inferior wedge with a corresponding change in the radial peripapillary change in the inferior wedge area. Example of same wedge with GCC showing you the change and the corresponding change in the visual field. So these are a few examples. How does the OCT actually differ from the OCT itself? The OCT angio actually detects both dysfunctional and so-called dead ganglion cells, whereas the structural OCT can probably detect only the lost ganglion cells. So probably in very early glaucoma, sick dysfunctional ganglion cells have lower metabolism that leads to reduced capillary density. And this density is probably picked up with the OCT prior to the apoptosis of these ganglion cells. So we can probably detect glaucoma earlier than OCT. The other studies have shown that the OCTA parameters correlate better with visual field parameters than structural OCT parameters. This is partly due to the lessening of the floor effect of the OCT measurements, and probably the OCT has the potential to improve the monitoring of glaucoma in moderate to advanced stages where the floor effect comes into play with the structural OCTs. And a word about the ocular blood flow. So what do we do when we pick up a structural change in the blood flow, the change in the capillaries, or change in the reduction in the blood flow? So some of these studies have shown the effect of drugs in the possible role when you pick up a decrease in the blood flow. Again, various technologies have been used, and the one which has been most commonly used in the past has been the color Doppler imaging. And about 75 to 80% of all of these studies have shown that one drug which is possibly effective in improving or increasing the ocular blood flow could be dorzolamide as carbonic anhydrase inhibitors. And that's one thing which we could do when you pick up a change and a decrease in ocular blood flow. This is the only drug which is possibly have some promise of increasing ocular blood flow. There are many challenges of the availability and limitation of directly assessing ocular blood flow in humans, the technologies, the need for experienced technicians, and also to correlate the vascular findings with disease progression, which came first, the vascular change came first or the structural change came first, and of course the various treatment options, what are they available once you pick up some change in the ocular blood flow. So take-home message for the practicing clinician could be that estimate the ocular perfusion pressure and consider ocular blood flow studies in certain subset of patients. CDA has been an established tool for assessing the ocular blood flow, but has many limitations like as I mentioned earlier. The OCT angio is a more recent development, but is yet to be incorporated for routine clinical diagnostic use. I would consider ocular blood flow studies in normal tension glaucomas, unexplained progression in these kind of patients, and whenever you strongly suspect a vascular etiology as the cause for glaucoma. And this is from the first workshop which Professor Alan Harris conducted in Chennai. And we are fortunate to have worked with him since then, and we still continue to work with him and looking at mostly the color Doppler imaging and now the OCT angio and its role and the role of drugs in OCT angio. Thank you for your attention.
Thank you so much, Murli. I think that was wonderfully done, and it must have clarified for our people. And actually, we were discussing OCTA also before. So, Dr. Chandrasekhar, we'll be taking the questions in the end, I hope. Yeah, so I think the questions from the audience and the thing will be taken to the panelist in the end. So let's move on, and we have Dr. Manish Singh. Can you put Manish right, please? Yeah. So we all know him now. He is a star, rising star from Northeast, working in the BBI Foundation. But the great thing about him is that he is such a good teacher, and he has got so many presentations now. Along with that, he's a great cataract and glaucoma surgeon. And today he'll be telling us, when is it not glaucoma? I think that is also a very important thing for us because so many people are over treating. Over to you, Manish.
Yeah. Please allow me to share my screen. Yeah, thank you, sir. It's really an honor and pleasure to be a part of this program. So I thank you, Harsh sir, for such a nice introduction. I'll be speaking about when it is not glaucoma. Am I audible, sir?
Yeah, you are fine.
Thank you, sir. So we all know about glaucoma, that a majority of the glaucoma in our country is still not diagnosed. But also what we also know that 50% of the patient whom we are treating as glaucoma probably don't even have glaucoma. So like underdiagnosis is a serious problem. Over-treatment also has a very important problem, and it has got a very important impact on the society as a whole, because we know glaucoma has become like a stigma with increasing awareness about the disease. I'll share you how it all started. This patient I was seen almost 12 years back in early part of my training at Shankar Nethralaya. This was the patient who came to us. He's a 38-year-old gentleman already undergoing treatment for juvenile open-angle glaucoma for almost a year. The pressures was 12 millimeter mercury on brimonidine. Patient was already undergoing treatment. When we went to the records, the patient had a pressure of 22 millimeter mercury recorded with a non-contact tonometer maybe 4 or 5 years back. Angles were open on gonioscopy. CCT was on the higher side. And if you see the field, very advanced field loss in both the eyes. So basically based on the cupping and advanced field loss and the pressure of 22, the patient was put on medication. This is the OCT of the patient. You can see there is thinning of RNFL in both the eyes. But if you see the disc is very important. If you see the right eye disc is around 0.7 with some superior thinning. The left eye definitely has got advanced cupping. But the correlation of the disc and field is extremely important in glaucoma. You see the correlation of the right eye with the field. When you see a glaucoma patient with a 0.7 or a 0.8 cupping, we don't expect this type of advanced field loss. Plus the presence of pallor is something which goes beyond glaucoma. So whenever we have this type of mismatch between your clinical finding and your investigation report, you should think beyond glaucoma. And in this patient, when we took a detailed history, patient actually had a history of methyl alcohol poisoning. So a lot of these methyl alcohol poisoning will come to you after 2 years, 3 years, 5 years. They will come with cupping, which is sometimes very difficult to differentiate from a typical glaucomatous cupping. In these cases, a proper history, proper evaluation of the patient and correlation of your finding with the investigation is very important. Also, one point we need to highlight, a lot of time patient will send you a WhatsApp report or will of a OCT or a perimetry and ask your comment about glaucoma. It's very difficult to comment unless you've seen the patient in totality. And just looking at the perimetry or OCT can be misleading, because investigation, for example, like OCT will tell you whether you have RNFL thinning or not. Whether the RNFL thinning is because of glaucoma or for a traumatic optic neuropathy or because of an old retinal vein occlusion or a methylalcohol poisoning, this is something which you have to determine based on your clinical finding. So we cannot blindly rely on any of the investigation. So whenever you have these young patients with non-metastatic glaucoma, because we know non-metastatic glaucoma is a disease of elderly population. Young patient with non-metastatic glaucoma, too much of pallor, or defects obeying vertical meridian, early involvement of central vision, you should think beyond glaucoma. The reason also I shared this case because we know of late we are getting a lot of cases of methanol poisoning because of too much use of sanitizers. So we may get some cases like this in future which may mimic as glaucoma. Another very important thing is, especially for the young practitioners who have started practicing for glaucoma or in ophthalmology, glaucoma diagnosis is a life-changing diagnosis for the patient. And I like to share the story of this girl, Neha. The picture is just representative, which I've seen almost 10 years back. And she was around 24, 25-year-old. When she came to the OPD, she looked more like 35 or 36-year-old. She was depressed, taking antidepressants. And when I went to the record, patient was actually having a physiological cupping. On evaluation, we found it was a physiological cupping, but she was put on anti-glaucoma medication because sometime the NCT showed a pressure of 22, 23. Patient had large cup, and OCT showed some area of RNFL thinning, but the fields were normal. So in a busy OPD, when you make a diagnosis of glaucoma and you move to another patient, the diagnosis of glaucoma can have a very important impact on the life of the patient. For this particular lady, the marriage got cancelled because she was diagnosed as glaucoma, and the groom's family was not willing to marry a glaucoma patient because of the risk of hereditary factors. So this diagnosis is a very important impact. So whenever you are confused, you're not sure about diagnosis, don't use the term glaucoma. You can write say this suspect or raised IOP or ocular hypertension. And you can always reevaluate the patient after a week, 1 month. We don't need to jump into a diagnosis of glaucoma. I'll share one more case. Mr. Vadva, who came to us in 2012, already a known case of non-metastatic glaucoma. He was hypertensive. The left eye was lost due to fungal endophthalmitis post-cataract surgery. Right eye had a 6/18 vision with a significant cataract. Patient was already on one medication, which was beta blocker. Angles were open, pachymetry was fine. There was inferior thinning with a superior field defect. So we found that the patient was well controlled on one medication. You can see a mild inferior thinning here. Since the patient was well controlled on one medication, we thought we just go ahead with cataract surgery. The surgery was uneventful. Patient got a good vision and was then lost to follow-up. He came after almost 7 or 8 months. By that time, again, the vision was 6 and 6 normal vision. Patient was on prostaglandin, and there was some mild thinning and mild amount of pallor, which was not very significant. But the patient was very insistent that he's not able to see. And we thought he's just probably maybe just patient is maybe a little over demanding patient because the vision is normal. But since the patient was so insistent, we did the OCT macula was normal. We also did the perimetry, and we were surprised to see the perimetry report that there was a marked progression in just a matter of 7 months. From little bit of superior defect, there was a dense superior defect, and which was encroaching the fixation also. So whenever you have these patients with a marked progression on well-controlled intraocular pressure, there's certain investigation we should do. One is an office diurnal or a 24-hour diurnal if you have the logistics or the infrastructure to do it. In this case, the pressures were normal. We should also have a carotid evaluation, a cardiac evaluation to make sure we are not having any systemic factors which might be affecting the ocular blood flow and be causing this progression. Also, we should be doing a 24-hour blood pressure assessment and a sleep apnea evaluation. In this patient, if you see the fields again, this patient had a visual field where the fields were sort of respecting the vertical meridian and looked more like a quadrantanopic defect. Because in glaucoma, you have more of a field defect into the arcuate area and not such an early involvement of the fixation point. This definitely gives an indication that probably it is something more than glaucoma. And when we did a neuroimaging, patient actually had a suprasellar mass. This was a case of a granuloma, which was compressing the optic nerve and optic chiasma. The patient was referred to neurologist and was later found to have a fungal granuloma. This probably had no relationship with the previous fungal endophthalmitis, but the patient had a history of fungal endophthalmitis few years back. So again, these type of patients who are established case of glaucoma, you know they are having glaucoma, but suddenly you see any progression, even with well-controlled pressure, these cases definitely you should look into other aspects, as I've already mentioned, plus also recheck your gonioscopy, look into the compliance issue, and have a neuroimaging whenever you have a doubt. The next case I'd like to share is Mr. Jha, who again came for consultation in 2014. The pressures were normal. This patient was already on prostaglandin analog. The vision was normal. CCT was 530. The gonioscopy had open angles. And if you see the field in 2014, the baseline pressures were also normal. The right eye was perfectly normal. Left eye, there was some superior defect, which looked, if you just see it, the field looks more like a low tension glaucoma or a normal tension glaucoma with early involvement of the fixation. And that is why the patient was already on treatment. This is the disc in the right eye, around 0.4, 0.5, looks to be pretty healthy. Left eye definitely has some inferior thinning. This is the data evaluation. So you can see definitely the left eye inferiorly is looking thin. But if you see in more detail, the left eye, which looked like a thinning, there is a grayish depression in this area. Also very important, whenever you're seeing this unilateral glaucoma, unilateral normal tension glaucomas, you should always think of secondary causes plus, because normal tension glaucoma is basically a diagnosis of exclusion. So you need to look into other aspects also. This was actually a case of an optic disc. CCT was not diagnostic, but there was some area of localized depression. But sometimes as OCT can be useful in patient with optic disc because of associated subretinal fluid. Sometimes you can see a membrane over the optic disc and cystic spaces inside the optic disc. So this was a case of optic disc pit. So whenever you have a patient like this, you should first stop anti-glaucoma medication, recheck the pressure after the washout period, which in this case is 4 to 6 weeks. We did an office diurnal after 4 to 6 weeks, and the pressures were all found to be normal. But very important, you should clearly mention in the file that patient needs to be under regular follow-up, because I had a patient with ocular hypertension where we stopped the medicine, the pressures were normal. 6 months down the line, the patient was again having normal pressure, but the patient was lost to follow-up and came back after 3 years with a frank glaucoma. So always keep these patients under follow-up, maybe 6 monthly or 1 yearly, but do mention that you should be under follow-up, because you never know, patient may have some other pathology or may have a raised intraocular because of some other reason in future. So whenever you're stopping medication, the responsibility is probably even more than starting anti-glaucoma medication. This patient had a follow-up of 5 to 6 years. You can see all the fields were stable because basically it was an optic disc pit. So there was no progression in this case. The last case I like to share, this is a patient, Mrs. Das, who again came for consultation, already established as a case of glaucoma for 4 years, already on prostaglandin, and the baseline pressure was 18 millimeter mercury. Patient came for a second opinion. Visions were normal. The pressure was normal. CCT was also 520. Angles were open on gonioscopy. You see the disc again in the right eye, maybe around 0.6 to 0.7. The superior rim slightly thin, but the disc is following the ISNT rule, and the RNFL also looking pretty okay. The left eye also is around 0.6 to 0.7, but a fairly healthy neuroretinal limb. So very important is seeing the disc first before you see the OCT or the HVF, so that you create an image about the disc before you see the investigation. So when I looked at the disc, I find the disc looks to be pretty okay. Even the red-free photograph, there is no RNFL thinning as such. But if you see the perimetry, definitely there was some nasal defect and superior defect. So just looking purely on the perimetry, you will be carried away that probably it's a case of glaucoma. This patient, when we did a dilate, and this patient was not having any learning curve because this field defects were persistent for almost 4 to 5 years. When we did a dilated evaluation, we found that there was a retinal scar, and this was just classically matching with this perimetry report. So if you have not done a detailed evaluation, you have not found the reason why these field defects are there, this patient will be treated for glaucoma for rest of his life. There's cost involved, there are the side effects involved. And when we So we dilated the patient and saw that this was the reason why the patient had this persistent field defect. Even the OCT also was done and it was normal and matching with our disc finding. So dilated evaluation is extremely important. Even with the most experienced glaucoma experts I've seen, undilated, you're bound to miss those early changes. You're bound to miss these retinal scars and disc hemorrhage. So always have a dilated evaluation. In case the patient is having angular glaucoma, you can do a PI and then dilate and do a detailed evaluation of the disc. So to conclude, I'll say every patient of a glaucoma deserves a comprehensive evaluation. Field and disc correlation is extremely important. Don't rush to diagnose a glaucoma, normal test of glaucoma 1 week, 2 week, 1 month. Nothing is going to happen. Take your time. If you're confused, reevaluate the patient after a week, 1 month. Whenever you have established patient with unexplained progression, do investigate to try to find any cause. And regarding neuroimaging, every patient with atypical presentation or atypical progression, do consider neuroimaging. Definitely the cost is involved, but even if you diagnose one patient with a tumor or a granuloma or some other pathology, is going to change the life of the patient. So whenever you have a doubt, do consider neuroimaging. Thank you so much.
Thank you, Manish. I think that was really beautifully done. For all the audience out there, and especially the students, I think the message was so loud and clear that not to make people depressed, their lives can fall apart if you make a wrong diagnosis, which so many times, so many of your younger colleagues do it so lightly. Thank you so much, Manish. Each case was a gem, and we'll discuss in the end. And now we have Dr. Sunita Dubey, who's the head of glaucoma unit and quality assurance at the Shroff Charitable Eye Institute in New Delhi. And the only thing I want to say about her is that I have seen her grow, and today she is one of the finest surgeons that I have seen. She performs live surgeries of the most complicated cases in glaucoma and even in cataract at all the important institutions that are there in our country. So today she'll unravel for us the mysteries of normal tension glaucoma through some case presentation. She has done a fellowship in Wills Eye Hospital, and she's really a wonderful teacher. So Sunita, please go ahead and share your slides.
Okay, thank you, Dr. Harsh, for the wonderful introduction. And I would like to thank CIPLA and AIOS for giving me this opportunity. Can you see my screen?
Yeah, it's there.
Yeah.
You can enlarge the slide.
Yeah, sure.
Yeah, that's it. Go ahead, please.
Yeah, so I'll be talking on normal tension glaucoma. And as we know, NTG and POAG represent a continuum of open angle glaucomas. While intraocular pressure is the predominant causative risk factor in POAG, additional IOP independent factors, especially the vascular factors, are said to have a role in NTG. And this has been emphasized by the previous two speakers also. NTG accounts for a significant percentage of all forms of open angle glaucoma, especially in East Asia. And in Japan, in one of the studies, showed that 92% of the POAG had an IOP of less than 21 millimeter mercury on presentation. And also in Baltimore Eye Study, which is a landmark study, almost 60% of the patients had IOP of less than 21 on presentation. So are there any differences in presentation which we see clinically of these patients from POAG? Yes, there are some differences. These patients present with focal rim loss, focal RNFL defects, and the visual fields which are closer to the fixation. And most importantly, there is increased prevalence of disc hemorrhages. So these patients do keep having disc hemorrhages on and off. And also it's been said that NTG patients who present with mean IOP in low teens, that is if they present with the pressures of less than 15, there is a possibility of having different pathogenesis and progression patterns. So let me take you through a few of interesting cases which are suggestive of non-IOP related factors. So this is then one patient who presented to us in 2010. There was no significant positive history. And on examination, the visual field, the visual acuity was normal, the IOP was normal, open angles, but you see this definite glaucomatous optic neuropathy with optic disc changes and the RNFL changes and corroborative visual field changes in the right eye as well as in the left eye. You can see this inferior RNFL defect and superior visual field defect. So we thought in terms of normal tension glaucoma, and we did the diurnal variation along with blood pressure. And that time we could do the trigger fish also, 24 hours IOP recording. And as you can see, there was not fluctuation, much fluctuation for 24 hours. The pachymetry was normal. So we thought it's a normal tension glaucoma, and we just probed deep into the history of asking all kinds of history of trauma, steroids, migraine, intolerance to cold, neurological symptoms or difficulty in breathing and so on and so forth. But everything was within normal limits. And even the patient is educated, and he wanted to undergo all kinds of investigations to rule out any morbidity, associated co-pathologies. So, but everything was normal. So the patient, we put the patient on one anti-glaucoma drop, and patient had been following up. And in 2006, we could see some changes here in the visual fields with associated disc findings, and in the right eye, but in the left eye, it was stable. So we just thought, are we dealing with a progressive normal tension glaucoma in a young patient? Is there any possibility of a vascular anomaly? Since patient didn't give any history of hypertension, we just got the ambulatory BP monitoring done, and there were some spikes of a rise in intraocular pressure. And again, that time, Dr. Harris and he were visiting, and CIPLA was holding a lot of workshops of color Doppler imaging. So we got this patient done, and there was some changes in the end diastolic velocity and resistive index. So increase in the resistive index and low end diastolic velocity, and suggestive of maybe decreased ophthalmic perfusion pressure and decreased ONH. But however, to our pleasure, this patient has been following up for the last 9 years, and you can see the rate of progression is pretty low, just 0.7% per year. So this patient is not progressing that much, and he is a stable patient, a slow progressor, and he is just doing well on one monotherapy. Second patient who presented with a history of acute blood loss, he presented in 2003, and the vision was normal, but definitely there was a glaucomatous optic neuropathy with the corresponding changes in the visual fields. The DVT and BP was normal, and we just thought it could be a one-time event because he had a history of blood loss, and it could be non-progressive. And we didn't that time start him on treatment, but we have been following this patient since 2003, and now 2020, that is 17 years, he has been progressing, although not very fast. The rate of progression is 1.7%, which is considered to be pretty moderate, because if it is more than 1, it is considered to be moderate. And we have been following up this patient, and now he has developed a little bit of cataract, and we stepped up his treatment. Now the question is, since he wants now cataract surgery, whether we should plan glaucoma surgery or just keep him on maximal medical therapy. So another patient, again, a young patient, obese, male, and he has a family history of glaucoma, and he has been taking his depression, antidepressants for the last 20 years. Again, there's no history, positive systemic history. Anterior segment evaluation was normal, but definitely there is some changes in the disc. Here there is some RNFL defect and inferior RNL, NRR thinning in the right eye more as compared to left eye. CCT was normal, and there were changes in the fields as well. And again, to our surprise, this patient also progressed over a period of 3 years, and just took out his IOP recording from EMR. There was not a single event of high intraocular pressure, and he was on one medication. When we probed deep into his history, he did give, his wife gave a history of disturbed sleep cycle, snoring, excessive daytime sleepiness, and fatigue. So we could be dealing with an obstructive sleep apnea in this particular patient, and he was advised polysomnography. However, we still have to get his reports of polysomnography, but there's a definite history of increased snoring and disturbed sleep. So there's definitely some role of vascular risk factors in causation of NTG. And Flammer, who has done a lot of work in NTG, has described a syndrome which is called primary vascular dysfunction, where there's not pathological abnormality, but these patients do present with cold extremities, low BP, decreased thirst, and tinnitus and migraine. So etiology of NTG is multifactorial, and cardiovascular system evaluation plays a very important role. And so all these factors, as we have already discussed, in nocturnal hypotension, autonomic dysfunction, intracranial pressure, and obstructive sleep apnea. And Dr. Murli has already talked about the importance of low perfusion pressure, as it increases the risk of development of normal tension glaucoma. So just to emphasize, all these systemic factors which are associated with vasospasm or endothelial dysfunction can lead to autoregulatory dysfunction, which is not a very uncommon phenomenon. And it is an imbalance between sympathetic and parasympathetic activity with a preponderance of sympathetic system. So eventually leading to autoregulation dysfunction and decreased ocular perfusion pressure. So a word about this obstructive sleep apnea, which is now coming up as an important risk factor for glaucoma and should be ruled out, especially in progressive NTG. And we do get to see patients who have some these sleep problems. And this is characterized by recurrent, complete or partial interruption of normal breathing due to functional occlusion or collapse of upper airway during sleep, and which leads to decrease in arterial oxygen saturation and rise in carbon dioxide saturation during sleep. And as a result, decrease in the ocular perfusion pressure and glaucomatous optic neuropathy. So these patients, rather the family members, they gave a history of habitual loud snoring on probing. So this question must be asked to every patient who's slightly obese and who has floppy eyelid syndrome. So this history is very important. These patients also complain of lack of energy and reduced concentration, dry throat on waking up and morning headache. And the diagnosis can be made by polysomnography, and the severity of disease can be calculated by the AHI. And if it is, basically per hour, they calculate the apnea hypercapnia index. If it is more than 15, it is moderate, and more than 30 is considered as severe. And CPAP is the gold standard technique to correct these anomalies, and the patients do improve a lot, and the progression of NTG may come to a halt when you treat such conditions. So just to summarize, it's very, very important, as has already been said, NTG, we make the diagnosis as a diagnosis of exclusion. You have to rule out POAG, and it's very important because if there is an increased diurnal fluctuation and thin CCT, it could lead to a possible misdiagnosis of NTG, which we do not want to make. And also gonioscopy is very important, a thorough clinical evaluation, because if you don't do gonioscopy, you may miss out on the primary angle closure disease, which can lead to to high IOP, and also subtle signs of pigmentary glaucomas and pseudo exfoliation glaucomas, which could lead to episodic rise of IOP, and you can miss them if you don't do a proper evaluation. History, again, if you don't find high IOP, you have to ask history related to migraine, Raynaud's. You can just feel the hands of the patient, the cold hands, episodes of shock, headache, sleep apnea, and other neurological disorder. Again, very important history which you need to ask is the habits of the patient. As we know, the increasing water intake in the morning, 1 to 2 liters of water, and yoga has become very popular as for health, obvious health benefits. So you need to rule out excessive water intake in the morning, and yoga exercise where the patient holds breath, or which is done with the head down position. And the history of steroids, again, you have to rule out history of steroids, the skin creams, the systemic on inhalational steroids, and use of beta blockers. The systemic history is very important. And in patients where if they don't give any history of blood pressure, hypertension, and if they're progressing, I think it's a good idea to get a 24 hours blood pressure monitoring. And MRI is not indicated in all patients unless the patient is a young individual with typical, as Dr. Manish had shown, the neurological field defects respecting the midline or the quadrantopia. And when the disc pallor is more than cupping, you can advise MRI also, and the peripheral vascular diseases. So just a word about the management. Again, IOP reduction is the mainstay of treatment in normal tension glaucoma also, because CNGT study, which is the landmark study for normal tension glaucoma, demonstrated that a 30% reduction favorably influenced the progression of the disease compared with the untreated NTG. So I think IOP reduction is the mainstay, and we still advise PG analog as the first choice of treatment. Although brimonidine and zorzolamide are known to improve, neuroprotection and vasoprotection, surgery may be required in patients who continue to progress even after achieving the expected IOP reduction. But it is rare to see a very fast progressor unless there is some obstruction somewhere in the major vessels. Normal routine, normal tension glaucoma patients, the progression is slow, as I had shown in my patients. In a meta-analysis, it was shown that the progression rate is not more than 0.5 per year, which is not very high. So you need not be in a haste to manage these patients surgically. And the role of other agents like calcium channel blockers and ginkgo biloba is still not proven yet. But one important point is you need to send the patient for cardiovascular evaluation to identify if there is any nocturnal hypertension or any other problem like that. So to conclude, in NTG, consideration must be given to the vascular factors also, more so if the patient is progressing, although you have to rule out the diurnal fluctuation and central corneal thickness, and detailed systemic evaluation and history. And till date, controlling IOP remains the mainstay in the management of NTG. However, neuroprotective agents are the interesting area of investigation for treatment of NTG for future. Thank you very much for your kind attention.
Thank you, Sunita. I think that was really nicely done, because you had demystified when to look for, what to look for in a normal tension glaucoma, and those of which are the patients to treat and how to investigate. Thank you so much for clarifying that for us. I would request all the audience and the students, especially if they want to ask the questions, they ask the experts tab is there. So kindly use that, and take this opportunity, because one of the finest people in glaucoma are right over there with you in the panel and giving the lectures, which are really right up to the heart of daily practice in glaucoma. So use the time, use the questions to ask them whatever you feel like. Now we'll move on to another very, very important subject: how to detect progression and how do we really tackle that progression if we find that. And for that, we have a very, very humble genius, Dr. Harsha Rao, who's many a times not even visible, and yet very few people know that he is one of the finest researchers that we have in the country today, with over 100 publications coming from Narayan Netralaya, Bangalore. And we will request him to give his opinion on how exactly to do this task. Harsha, please.
Thank you, sir. I hope I'm audible.
Yeah, a little louder, Harsha. You are always so mild.
Sure, sir. So thank you, sir. I thank AIOS and Dr. Verma for this opportunity, and for CIPLA to putting this program together. I'm talking on detecting and tackling glaucoma progression, which is a vast subject by itself. So I would at least try to touch upon the more important points in this topic. These are my financial disclosures, nothing particular of interest to today's discussion. We all know that glaucoma progression refers to progressive death of retinal ganglion cells, and we detect this clinically using a lot of surrogate markers. Detecting progression clinically is one of the most challenging aspects of the glaucoma management, and going forwards, we will discuss some of the reasons for this. Methods to detect glaucoma progression can be broadly classified into methods to detect structural progression and methods to detect functional progression. Functional progression is detected mostly predominantly on standard automated perimetry. Structural progression in glaucoma refers to the progressive enlargement of the cup, progressive thinning of the neuroretinal rims, progressive thinning of the RNFL, etc. So structural progression can be detected using pictorial documentation of disc findings, which essentially are very good disc drawings, which have become a challenge now in this era of EMRs, but they are very useful in detecting progressive changes. Serial photographs, once again, is a very good method of detecting glaucoma progression along with imaging. So serial photographs of the disc, good quality stereo images are wonderful to detect progression, especially when you have a case like this, which showed a inferior rim excavation in 2006. In 2008, there was a disc hemorrhage and a developing RNFL defect inferiorly. And in 2019, there was a notch inferiorly, resolution of the disc hemorrhage, but an enlargement and probably a progressive thinning of the RNFL defect. So you can appreciate the more darker hue to the RNFL defect in 2019, which tells us that the thinning is more progressive now. Methods to detect progression on the standard automated perimetry and on imaging have similar principles and can be discussed together. These are the methods. Let's go through some of the more commoner methods to detect progression both on perimetry and imaging. The first one is the clinical judgment method, which essentially means putting together the reports of follow-up examination one next to the other and analyzing what the changes happening. Here is the visual field reports of this patient, one done in 2002 and the other one done in 2005. So we can see that the mean deviation is worsening, the pattern standard deviation is worsening from 4 decibels to 7 decibels, and the threshold sensitivities also in the superior hemifield show reduction in this particular sector. So this is how we look at the clinical judgment method. However, this is a subjective evaluation, and the same thing applies to the imaging method also. Here is the OCT reports, one done in 2013 and one done in 2015. And we can look at the RNFL thickness in the quadrants, in the Clark-R sections, and notice that the RNFL thickness in these smaller regions are reducing during this time, both in the superior and the inferior pores. However, this is quite time consuming. It takes a lot of time. We'll have to give careful attention to each of the smaller details here. And more importantly, we need to know what's the test-retest variability of these measurements, and we need to account for this to come out with clinically relevant information out of this method. That's the reason we now have more analytical methods to detect progression. The first one is the trend analysis. So in the trend analysis, the change in the parameter over time is analyzed and the slope is provided. This tells us at what rate a particular parameter is changing over time, and that can be used to decipher whether the change in the parameter is happening at a rapid pace or it's at a slow pace. On the visual field, trend analysis is used for the global indices like mean deviation, pattern standard deviation, and the VFI. So here in these plots, the MD here, the PSD here, and the VFI here are plotted over time at each different visits, and the change happening in each of these parameters is provided as a slope here. As you can see, the MD slope is minus 0.8 decibel per here, and the slope is significant. The more popular one nowadays is the VFI slope. However, these global indices on visual fields have their own limitations. Cataract and other causes of generalized depression affect the mean deviation. PSD artifactually improves in advanced stages of the disease, and VFI also has limitations. It's less sensitive than mean deviation in early diseases, and the linearity assumption of VFI is broken in advanced stages. The trend-based analysis with OCT also evaluates the average parameters, the average thickness measurements, be it the RNFL or the GCC thicknesses over time, and the rate of change of these parameters are given over time with their clinical significance, with their statistical significance. Here is an example which shows both the RNFL and the GCC thinning with time, and both these changes have been statistically significant. The trend analysis also has its own set of limitations. It requires multiple examinations, and we essentially don't know what's the magnitude of change that is significant, though it's generally believed that any change which is happening over and above the age-related change can be considered clinically relevant. Also, the linearity assumption may be broken, and this trend analysis is greatly affected by the outliers because most of these trend analysis use the linear function of time. Here is an example where the rate of progression, which is minus 0.7% per year on VFI, has almost doubled when the outliers have been removed in the analysis. So this is something which we need to be mindful of and remove the outliers, unreliable examinations from the trend analysis. Using global indices once again has a lot of issues. We know that glaucoma progression happens in more localized areas, and using global indices, global parameters, masks the changes happening in focal areas. Event analysis is where the follow-up examinations are compared with baseline examinations, and a change in the parameter of certain magnitude is considered as a change based on predefined thresholds and definitions. The event analysis on visual field is based out of the EMGT trial criteria, where a point which has changed in its threshold sensitivity by a magnitude over and above the retest variability of that point seen in stable glaucomas is considered as progression. Here is an example of an eye which has been stable over time. As you see, there is this message coming out from the event analysis which says no progression detected over time. And this is an example where there is progression detected. You see that there is likely progression, and you also see a trend analysis which is more obvious. The limitations of visual fields for detecting progression is primarily from the fluctuations which arise out of these thresholds, especially in diseased points or diseased areas. Here is a good example of it. We have this glaucoma patient whose baselines are done in 2003, and subsequently a progression was detected on event analysis in 2005. There is likely progression. But what happens next is interesting. In 2007 and 2008, the fields are very similar to the baseline examinations. There is no progression. Once again, over time, in 2010, subsequently 2013, 14, once again, it says that there is likely progression. So this is the fluctuation which we see regularly on visual field thresholds, and this is one of the limitations. The event-based progression analysis on OCT is also on the similar methods. There are two analyses which happens on the OCT, the serous OCT at least. One is the RNFL thickness change map, where the change in the RNFL thickness, the reduction in the RNFL thickness at superpixel levels are analyzed. And if a cluster of 20 superpixels show a reduction in RNFL thickness greater than that seen, greater than the test-retest variability, that's called as progression. So this happens both on the RNFL and the GCC maps. The other event analysis in the OCT happens on the T-SNP profile. And if a reduction in the RNFL thickness is seen in a 20-degree sector, that's called a progression on the T-SNP profile. So most of these reports combine both the trend and the event analysis and give the analysis to us. We know that the event analysis is more sensitive in picking up progression and also picks up progression earlier than the trend analysis. However, the trend analysis also has an advantage that it can be projected to the future. So it has a prediction advantage. So you know that if the same trend continues, what would be the likely parameter value that would be reached in 5 years or 10 years down the line. A couple of quick examples here. So this patient followed up yearly with the disc photographs. I would just want to highlight the 2016 and the 2019 disc photographs here. As you can see, the inferior RNFL defect is enlarging. The upper border of the RNFL, which is here in 2016, has moved up closer to the macula in 2019. The visual fields also show a correlating enlargement of the nasal defect, also show a correlating enlargement of the parafoveal scotoma and the 10-2 fields, and the OCT also shows a correlating progressive RNFL thinning and the GCIPL thinning here. So this is an example where all the methods are correlating with each other very well, which is easy to confirm the presence of progression. In this example, so the disc shows an inferior notch and a superior RNFL defect. Very difficult to analyze any change with the disc photographs in this patient. Visual fields remain stable and the RNFL thickness also remains quite stable over these 3 time points. However, the GCC maps show that there is an enlargement in the zone of GCC thinning. So in this example, the GCC maps show a possible progression while the visual fields and the RNFL maps don't agree with it. So these are the common situations. In this example, you see a normal looking disc in 2015, developed an inferior rim excavation in 2016, subsequently a disc hemorrhage, an RNFL defect, which kept on progressing. So this was correlated very well with the RNFL map and the GCC maps. However, when we can put everything together, what we see here is that the progression is picked up earlier by the GCIPL maps. GCIPL maps are showing a progressive thinning in 2016. The RNFL maps are showing a progressive thinning in 2018, and the visual fields are showing a progression only in 2019 and 2020. These are 24-2 fields, by the way. So there is always a debate on visual fields versus imaging for the early and accurate detection of progression. That's once again a big chapter in itself. However, the important thing for me to stress here is one factor which decides which test you choose for detection of progression is the severity of the disease. In early and moderate severity of disease, imaging methods probably are better to pick up change, and in moderate to advanced disease, visual fields are better to detect change. The primary reason for that is the floor effect. We alluded to this earlier also. The floor effect is seen on the structural measurements. We have this example where the visual field is showing an obvious progression. However, the RNFL maps are not showing any change because the structural measurements reach a floor at certain level of disease severity. So to confirm progression, we need good quality test, good reliability indices of visual fields. And before you confirm progression, you need to make sure that the relation of the progression locations on your tests are in relation to the original defect, because that's how commonly glaucoma progresses. And you also have to look for accompanying clinical evidence before you make the decision of progression. And whenever in doubt, repeat the test. So I'll briefly go into the tackling progression part. So before that, we need to remind ourselves that the aim of glaucoma management is to slow down the progression of the disease to an extent that minimizes the likelihood of glaucoma-related visual disability during the lifetime of the patient. What this means is that it's perfectly fine if you don't change a treatment, even in the presence of confirmed progression, if you feel that during the patient's lifetime, this amount of progression is not likely to affect the visual quality of life or would cause visual disability. Once you do that, and once you know that this is a progression which is likely to cause visual disability to the patient, we move to the next steps. When you have confirmed progression, the first simplest thing we do is to see what the office IOPs are. Are they higher than the target levels? Are they close to the target levels? If they are higher than the target levels, we need augmentation of therapy. Before that, we need to check for treatment compliance. This is what we assume, but we'll have to carefully check the compliance, whether the patient's using the medicines appropriately. Always repeat gonioscopy whenever the clinical picture changes, especially in the situation of an angle closure in a previously diagnosed open angle glaucoma eye. If the IOP, office IOP is at the target level, the first thing is to rule out other pathologies. We saw vein occlusions, we saw retinal scars, it can be ARMDs, which can mimic glaucoma progression. We need to rule them out. Once again, even if the IOPs are at the target level, check for the compliance, because there can be spikes happening in the non-office hours. Repeat gonioscopy once again, because the angle closure components can cause IOP spikes in the non-office hours, and then do the diurnal IOP checks. We heard about all these other uncommon causes for progression, be it sleep apnea, water detoxification, yoga postures, all these can cause spikes in intraocular pressure during the period of the performance of these activities. Then we also heard about reduced ocular perfusion and neuroimaging by previous speakers. How do we treat them? The only option, or the most successful option we have to tackle progression, is to augment therapy. In addition to it, I also in some cases advise regular physical exercise. I also advise to avoid overeating, a method of caloric restriction, and some activity to reduce stress. Can be meditation, can be time away from, say, WhatsApp, time away from spouse if that reduces stress, so etc. So augmenting therapy, the simple things first. If the patient is on a single AGM like a beta blocker or an alpha agonist, we know from sleep lab experiments that the nocturnal IOP reduction is not very favorable with them, and so shift them to PGA. If the patient is already on a PGA, and in addition to PGA he is on either a beta blocker or on an alpha agonist, shift to a PGA with carbonic anhydrase inhibitors, because that provides an additional reduction in the intraocular pressure during the nocturnal hours. If the patient is on maximum medical therapy, consider a filtering surgery. And if the patient has accompanying angle closure with cataract, you can consider cataract surgery. So tackling progression is once again a very huge topic, and it's so much individualized as we saw with previous case examples. So to summarize, detecting progression is one of the most challenging aspects. No one method to detect progression is complete, so you may have to use information from multiple tests sometimes, and then the therapeutic changes are required in patients who are likely to develop visual disability, and not in all of them. Thank you.
Thank you, Dr. Harsha. Some of the tips were really interesting, and I hope that the people have brought it up. The time away from the stress, whatever is causing you the stress. And definitely meditation is, we were discussing even before, does wonderfully well. I think he's really shown beautifully how exactly to detect progression. I think we need to really work hard on that, and exactly how we have to tackle it is very individualized, like he rightly said, but he has shown you all the ways on how to do it. And Dr. Chandrasekhar, I was quite shocked to see that we were actually ahead of time. So do you want to take some one or two questions right now, sir, or do we all take it at the end?
We will take it at the end.
Okay, we'll take it at the end, as sir says. So we can now go on to Dr. S.S. Pandav. So Dr. Pandav can, we all know Dr. Pandav as the head of glaucoma unit in PGI. And right now he's sitting very quietly 6 kilometers away in his village from Palampur in the hills, and a beautiful place. And that is where from he has come to become one of the leading faculties in the country. And the only thing you can read the rest, but what I want to say is that he's such a humble human being. But anywhere beyond Delhi, in entire northern India, right till Kashmir, if there's a very difficult case, they go searching for Dr. Pandav to do that complicated surgery. And he has been doing the most difficult cases that I have seen. And obviously, another thing that actually is not written over here is that he's a wonderful human being, and the way he treats his patients. Plus, he's also some kind of an IT wizard, because he developed the whole program of how to feed things into the PGI, this thing, so that they could actually use it. Now, there are so many IT people who are doing it, but he did it the first time for the PGI. So now he'll demystify for us why exactly pseudo exfoliation is more difficult, or how is it different from standard glaucoma. So Dr. Pandav, can you come down from the village to us and start the sharing? Thank you so much.
Thank you, Dr. Harsh, and thank you, AIOS, Dr. Lalit, particularly, and CIPLA for providing this platform. I'll be talking about pseudo exfoliation glaucoma, how it is different from POAG, no financial disclosures. Pseudo exfoliation, as you know, is a common association with cataract and glaucoma, and this, in fact, is the most common identifiable cause of secondary open-angle glaucoma. And we know this is a systemic disorder, and it's not only linked to the eye, but it has some systemic features as well. We don't know the exact etiology, but exposure to ultraviolet radiations, some relations with the high altitude have been implicated, but it's not really proved. Pseudoexfoliated glaucoma, or XFG as sometimes abbreviated, is common in patients with the pseudoexfoliation syndrome. Pseudoexfoliation syndrome means that you have features of pseudoexfoliation, but there's no glaucoma. And more than half of these patients actually develop glaucoma over a period of time. And if you look at the worldwide scenario, the prevalence varies in different ethnicity and different countries, but overall it is believed that at least one-fourth of OAG patients, they have pseudoexfoliation as underlying cause. The question is how it is different from POAG. Pseudoexfoliation glaucoma is a distinct entity, and it is very distinct from POAG in terms of presentation, pathogenesis, outcome to the treatment measures, and even the underlying genetic and molecular mechanisms are different in pseudoexfoliated glaucoma as compared to POAG. So the typical clinical profile is that you have a deposition of white flaky material, which is the hallmark of pseudoexfoliation syndrome and glaucoma. And you can see on the lens, usually seen on the anterior surface of the lens, but it's actually deposited all over the anterior segment. And it's a bilateral disease, but to begin with, at least a third of the cases may be unilateral. But if you follow them up enough for 10, 20 years, they will develop pseudoexfoliation with or without glaucoma in the other eye as well. And this is a 60-year-old male with a IOP, came with a high IOP 40 and 24 millimeters of mercury in the right eye and left eye. And you can see there's a telltale signs of pseudoexfoliation in this patient, in this eye. In the right eye, you see the pseudoexfoliated material there deposited. The zonules are affected there. In fact, they are not there, and there's some subluxation of the lens is already happening. And in the picture below, that temporal meshwork is heavily pigmented, which is usually happens in these. And also there's a pigmentation anterior to the Schwal-Base line, what is known as Sam-Halsey line, which is very often seen in these patients because the pigment dispersal. And also you can see on the gonioscopy, there's a flaky whitish material which can be seen in the angle. So these are the usual telltale features of pseudoexfoliation. And if you look into it, it is not very hard to miss the diagnosis. The one thing characteristic about these patients is that they have higher IOP fluctuations as compared to POAG. Now, POAG is also known to have diurnal variation and also the intervisit fluctuations. but they are not as pronounced as we see in pseudo exfoliation glaucoma. So diurnal as well as intervisit IOPs are very high. Fluctuations are, the magnitude of fluctuation is higher in pseudo exfoliation glaucoma. In fact, the pressures going beyond 30s and 40s is also usual in pseudo exfoliation, which is a little uncommon in a typical primary open-angle glaucoma. And also, despite the open-angle glaucoma, if you dilate these eyes, if you put a dilate in the eye, if the people dilates, they can experience a high spike after dilatation. So that also be kept in mind when you're dealing with pseudo exfoliation patients. This also results in kind of a risk of progression, which is higher in pseudo exfoliation as compared to POAG. So the progression in POAG without treatment is almost 3 times faster as compared to POAG. And this actually data has come from the EMGT study where you had a group which was untreated, and that untreated group had POAG as well as some pseudo exfoliation patients. And if you look at when you follow them up, those who progressed, it was seen that the pseudo exfoliation had a higher chance of progression, which is almost 3 times more than POAG. So there's a difference in the rate of progression as well. It has also been suggested that the lamina cribrosa of pseudo exfoliation patients is probably more vulnerable to the IOP fluctuations. Now, the IOP fluctuations are higher in these patients, as well as lamina is also more vulnerable, probably because of the pathology which affects the anterior segment also affects the lamina cribrosa, and that is more vulnerable to enhanced or exaggerated IOP fluctuation, as well as perhaps even the normal range of IOP fluctuations. So if you look at from pathogenesis point of view, there's a gradual accumulation of abnormal proteins, which is a kind of fibrillar material, whitish fibrillar material, which is abnormal cross-linked proteins actually, which are metabolic products of elastin and some other extracellular matrix components, and they get deposited along with the pigment in the temporal meshwork, so they're blocking the exit of the aqueous from the anterior chamber, and also a long-term deposit would lead inside some pathological changes in the temporal meshwork itself. So that leads to high IOP, and this is because of the abnormal elastin metabolism, basically, and as I mentioned, there are also abnormal metabolism of the other extracellular matrix components as well. Other thing about different in pseudo-exfoliation glaucoma compared to the POAG is that the response to anti-glaucoma therapy is also a bit different, and achieving target IOP with medical therapy is a little difficult in pseudo-exfoliation glaucoma as compared to POAG. Especially, there is a loss of effect of the drugs, and this is particularly marked with the timolol, and this study, as I quoted below, the 3 years, the patients who were controlled on monotherapy with the timolol initially, after 3 years, only 8% of them remained controlled in pseudo-exfoliation glaucoma group, as compared to almost 1/3 in POAG. Prostaglandins seem to work better in both of these entities. Other anti-glaucoma drugs, they are effective in reducing intraocular pressure. However, there's an increased requirement of anti-glaucoma therapy with increased follow-up. Now, which that's true for both POAG as well as pseudo-exfoliation glaucoma, but perhaps it's a little more pronounced in pseudo-exfoliation disease as compared to pseudo-exfoliation glaucoma as compared to POAG. The laser therapy in pseudo-exfoliation is effective in lowering intraocular pressure. And if you look at the 2 years probability of success in pseudo-exfoliation is almost 80%, which is, I think, quite comparable with the POAG. So we can expect a IOP reduction of 20 to 40% IOP reduction in pseudo-exfoliation patients with laser treatment. However, if you compare the ALT, if you head-to-head with the POAG versus pseudo-exfoliation glaucoma, then it appears like that there is actually is higher drop in intraocular pressure after in pseudo-exfoliation patients after laser trabeculoplasty. Now, this could be related to because the reduction in IOP is actually a function of initial IOP, the baseline IOP, and which is usually higher in pseudo-exfoliation group patients as compared to POAG. And also, but the important thing is that the attrition rate is also high. And in this particular data study, the probability of success after 8 months of ALT was just about 49% in pseudo-exfoliation group as compared to more than 77% in POAG. So that means initially there's a good response, there's more IOP lowering in pseudo exfoliation group, but with time that IOP lowering actually wanes off and you need more anti-glaucoma drugs in these patients. ALT is mostly now replaced by SLT. Most people do SLT, so how do they compare? So in this small study on pseudo exfoliation group where SLT and ALT were compared, there was no significant difference in the IOP reduction in both the groups. So they are more or less similar in reducing intraocular pressure. Then comes the the last measure, the surgeries. How do these patients respond to surgery? So the trabeculectomy is the most common filtering surgery for glaucoma still, and it appears that trabeculectomy provides actually a little better IOP control in pseudo exfoliation glaucoma patient as compared to POAG. This could be related to the disease itself, or also partly, could be because of the age group, because pseudo exfoliation is a bit of the age related. POAG is also age related, but I think they are a little upper in the age group. Long-term success of trabeculectomy in pseudo exfoliation glaucoma may be better than POAG. So I think if you look at the literature, it suggests that maybe trabeculectomy actually does a little better in pseudo exfoliation group as compared to POAG. And there's also a suggestion that pseudo exfoliation patients who have undergone trabeculectomy, they have a little lower rate of progression as compared to POAG, where filtering surgery has been done. So this overall basically suggests that trabeculectomy tends to do better in pseudo exfoliation group patients as compared to POAG patients. So this is the drug-free period after trabeculectomy in these patients, which is a little longer in pseudo exfoliation as compared to trabeculectomy POAG patients. However, this comes with a caveat that the risk of complication is also higher in trabeculectomy. So we see more high FEMA, shallow ACEs, choroidal hemorrhages in pseudo exfoliation group patients as compared to trabeculectomy. So that has to be kept in mind. Now, trabectomy is a newer procedure, and this basically you remove the trabecular meshwork with all the pigment and debris along with, and that tends to the literature, whatever we have, it suggests that it is a better procedure for pseudo exfoliation glaucoma patients as compared to POAG patients. Trabecular aspiration has been, especially used for pseudo exfoliation group patients, and it suggests that if you combine phaco and trabecular aspiration, which can be easily done, you get a good IOP response afterwards. Now, obviously, this procedure is not designed or work for a POAG patients. Then the effect of cataract surgeries again is important. So we know that most patients, they undergo cataract surgery, they experience some IOP reduction, and even in POAG patient, you can expect a 2 to 4 millimeters of IOP reduction after phaco emulsification. But this IOP reduction is more, significantly more in patients with pseudo exfoliation, who has pseudo exfoliation or pseudo exfoliation glaucoma. So both exfoliation, with or without glaucoma, they have lower IOP reduction after phaco emulsification. And this is quite sustained. And sustained and significant IOP reduction can be seen up to 7 years in patient with pseudo exfoliation syndrome. However, in patient with glaucoma, this sustained IOP lowering is not that sustained, and it has seen that IOP may go up in after 2 to 3 years time. So this sustenance part is little less if you have glaucoma, but still overall, these patients will need less anti-glaucoma medicine over a period of time as compared to POAG patients who have undergone cataract surgery. So there is a benefit of cataract surgery, which is a little more than the POAG patients as compared to POAG patients. But however, again, there's a caveat here. The cataract surgery, because of the problem with the zonules and other complications of the pseudo exfoliation, is 5 to 10 times more riskier. It has more chances of complications, and we all are aware of those things. So that has to be kept in mind before you when you are doing cataract surgery for these patients. So we know this is a systemic condition basically. So you have to look for the systemic considerations as well as the vascular dysregulation, arterial changes, even the heart rate regulation, and those are very well known pseudo exfoliation patients. Now, comorbidity with cardiovascular problems and other diabetes, hypertension. They are also there in POAG patients because of the age group. So in even POAG patient, you have to worry about the comorbidity, because that would affect how you treat these patients. But that consideration is a little more required in pseudoexfoliation glaucoma as compared to POAG patients. Then, as I said, there are the level differences at the level of genetics and molecular level also. And we know that POAG is associated with myelin and optineurin genes. This is kind of a very well established there. Whereas the pseudoexfoliation syndrome is actually is a problem with the lysyl oxidase like one enzyme system. And this, which is related to the elastin metabolism. So because there's a collagen and elastin is the integral part structure of the structure of the eye. And these are elastin-related genes which are defective. So their metabolism of elastin and some other extracellular components is defective, and that leads to accumulation of the fibrillar material and also weakens the structure of the globe in certain places. And that probably is the reason for. Now this association of, LOXL1 again is believed that has an association. However, there are some studies which suggest that it may not be so, and there may be some other genes involved which are not, and it's not clear at this point of time. We in our in India, we did in our part of the country, actually northern India, we looked at this LOXL oxidase gene, LOXL1 gene in our population, and actually we didn't find. These were a group of, I think, study on 100 and some odd patients, and we actually didn't find any association of these patients in our population. And similar lack of association has been reported in some other communities as well. So, but what we believe is that there's an abnormal metabolism of elastin and some extracellular components, and which is probably pseudoexfoliation syndrome has a genetic basis, but which patient of pseudoexfoliation syndrome will develop glaucoma, that probably is not genetically determined. At least we don't have any evidence to say that if there's another gene involved which converts these patients to glaucoma. So what is suggested is that probably in the environment factors or the internal homeostasis of the body plays a role in that. And people have found elevated levels of oxidative stress markers in the aqueous humor of these patients, and also decreased antioxidant protection molecules in the aqueous humor of these patients. So probably there's some lack of, these patients are more prone to have oxidative damage to the trabecular meshwork, which leads to glaucoma in these patients. To summarize, pseudoexfoliation is a common and distinct entity, quite distinct from the POAG, and it differs from POAG in many ways. There's a deposition of white fibrillar material, which is a hallmark of the study of this disease, which is not there in POAG. These patients tend to fast progress, and if they are not treated, the optic disc of these patients is perhaps more vulnerable because of the inherent defect in the elastin metabolism. And these patients also experience wider fluctuations. They also, which could lead to progression. Achieving target IOP with medicines is a bit difficult in pseudoexfoliation patients as compared to POAG. ALT and SLT are good they provide good initial lowering in these patients, better than POAG. However, their effect could wane off with time. And it looks like the trabeculectomy gives you better control in pseudoexfoliation patient as compared to POAG patients. Thank you very much once again for your listening and providing me. Thank you.
Thank you very much, Dr. Pandav. I think that was beautifully done, and we are quite clear now. I think Dr. Satyan is going to take over. Yeah, and so he'll introduce the next speaker.
Thank you, Dr. Harsh. Our next speaker for today is Dr. Shirisha Senthil. She's the head and director of glaucoma services at LV Prasad Eye Hospital. One thing, of course, all of us know Dr. Shirisha, but what I can remember Shirisha is when she is not winning a medal in any of the conferences. Most of the conferences she wins at least 1 or 2 medals. So that is what Dr. Shirisha Senthil is. So she's going to talk to us on managing secondary glaucoma in common situations. We all know that the secondary glaucomas, we can treat the intraocular pressure, but identifying the cause and treating specifically makes a lot of sense. Over to you, Dr. Sirsha.
Yeah. Thank you, Dr. Satyan, for the kind introduction. So, yeah, are the slides visible?
Yeah, we can see, Sirsha. Go ahead.
Thank you. Secondary glaucomas are those glaucomas where we know that there are secondary causes. It could be developmental, it could be acquired, and there are quite a few of them that we deal with on a day-to-day basis. Why is it important and why this secondary glaucoma is really close to my heart is that in the study that was published from All India Institute, if you look at just the profile of secondary glaucomas, you'll realize that the causes may be variable, but what is very interesting here to note is these are younger patients. They have a male preponderance. Most often because they are secondary, they could be unilateral. And more than 50% of these patients, in fact, it's about 63% of the patients have vision less than 2200 at presentation. They have intraocular pressures really, really high, sometimes going beyond. You can see the baseline IOP is more than 30, is beyond 45. So the least number of patients that they have seen is 45%. And as high as up to 78% of them had intraocular pressures beyond 30 millimeters of mercury. And they have very severe disease at presentation. So this just gives you the gist of what the secondary glaucomas are. Unlike the primary glaucomas, where we know that if you diagnose them early and if you're treating them appropriately, we should be able to save vision. These eyes, you can lose vision in less than a month's time. So that is the gravity of the situation. Hence, diagnosing them appropriately is very important for us to treat them well. So we know what typical angle closure looks like. The reason why I'm starting with angle closures, many times there are a lot of masquerades where we would be able to miss secondary glaucomas in these patients. And that's the reason why I'm taking you through this. So typical angle closures, you know, the sphincter changes that happen, sometimes they can be subtle, sometimes they can be quite obvious. You have angle closure, which is most often bilateral. And you can have a typical acute angle closure, which has features that all of us will be able to pick up. When do you suspect a secondary cause? Always, this is an untold finding or an untold sign that if you have an angle closure which is unilateral, always suspect a secondary cause. Having said that, if you have, let's say, bilateral angle closure, can there be secondary? This is something that I can take you through a few examples. A 21-year-old lady presents with very high intraocular pressure in both the eyes. One eye has normal vision, other eye has almost no vision, PL plus in one eye. So this lady has an angle closure which is very unusual for that age and with that high an intraocular pressure. No other posterior segment pathology noted. And we all know that we definitely have to rule out a ciliary body lesion or any kind of a thing that is behind the iris. So gonioscopy will give you some clue, but UBM is very, very important. And this patient has significant disc damage. You can actually see that. UBM showed multiple ciliary cysts all through 360 degrees. So this lady had a secondary angle closure, secondary to the multiple ciliary cysts. So unless you find out a cause, treating them the way we normally treat with a PI and going ahead with the medications is not going to help. So always think of a secondary cause, because what is the situation here that will help you to suspect is the age. At such an young age, is very, very unusual to have a primary angle closure. Another young male presented with unilateral high IOP. Right eye is 48, left eye was 19 millimeters of mercury. Angles significantly close, like a typical angle closure. Yes, male is a little unusual, but it's not that it doesn't happen. And this patient also, like I said, has an asymmetric presentation. So this patient had all features typical of an angle closure. We went ahead and did a YAG peripheral iridotomy, and of course we were following up that patient. Over a period of time, what we noticed is that the PI closed. So always we tell our patients that when we do a PI is patent always, PI doesn't close. If a PI is closing, there is something else that's happening in that area. Patient has developed a peripheral anterior synechia that is actually closed that PI, which means that you're dealing with a disease which is not primary. So this patient over a period of time, PI closed, and as we went by, this patient slowly started developing progressive iris atrophy and ectropia on UVA. Typical progressive iris atrophy, but this patient actually presented as a primary angle closure with absolutely no iris changes, and changes were there only in the angle. And this patient, fortunately, we also had a specular which we were doing over a period of time because of the young age at presentation and things like that, showed typical features of ICE syndrome. So we had to revisit the diagnosis. This patient had an ICE syndrome, possibly in the area where we have done a PI, we have triggered a little more of inflammation, and the synechia started developing because of the membrane that had grown from the corneal endothelium. So this patient actually, after all this, required at a later time point, I think 2-3 years later, required a keratoplasty in one eye. So unusual presentation, again, young patient, bilateral, but keep a watch. And findings of a closure of a YAG PI tells you that there is something else that is secondary and we need to rule out a second cause. A 19-year-old male patient was referred to us with pain, blurring of vision of one eye, in the left eye, and vision was 20/80, IOP was quite high, closed angles with new vessels on the iris. Right eye was essentially normal. If I show you a posterior segment photograph, essentially it is okay, except that in the left eye, if you see, media is slightly hazy because of the high intraocular pressure, and cupping was slightly more compared to the right eye. But otherwise, you don't have a posterior segment pathology that will help you to suspect the cause for the neovascular glaucoma in this patient. So the FFA showed delayed filling, and there were choroidal non-perfusion areas in certain places. The ERG showed reduced oscillatory potentials and also reduced amplitude of both A and B wave. What was a clue that was there right from the day one, but possibly we missed it, is on a dilated examination, you can see a localized cataract here. And this patient over a period of time also showed some amount of fluffy material in the anterior chamber. This patient had a ciliary body mass that was picked up on a UBM. And this patient was very, very unusual. I think this is the first of its case where this was a delayed presentation of a retinoblastoma. So usually medulloepithelioma or a ciliary body tumor is a more common cause, but this patient had an anterior retinoblastoma, which also had invaded the ciliary body, and this was the presentation. So localized, so unilateral angle closure, neovascular glaucoma, no posterior segment pathology that you will actually find out, always do a UBM. We should have done a UBM rather than going ahead and doing the other investigation. We can do the other investigations, but the first thing that should come to your mind is a UBM and a careful anterior segment evaluation. Had we picked up that localized cataract, we would have definitely suspected a ciliary body pathology. Bilateral sudden decrease in vision in patients with high intraocular pressure, you can have. This is again not very uncommon, but for the benefit of the audience who are there, I thought I should present this case. Again, a common presentation of a drug-induced angle closure secondary to this sulfur group of drugs that people use. So what are the typical features? Sudden decrease in vision, shallow anterior chamber, very high intraocular pressures, myopic shift in refraction. A patient who was not myopic earlier can actually accept a sudden myopic refractive error, now -2, -3, -4, and whatever it is. And these patients typically don't have a disc damage because this is an acute presentation. So always think of a drug-induced cause. How much ever you treat, this is not going to come down with your regular medications. We have to stop the offending drug and put the patient on topical steroids and topical cycloplegics and not do a PI for these patients. What is diagnostic is investigation, which is UBM. So clinically we can make it out. But if you have a facility where you have a UBM, please do it. We will be able to visualize a ciliocoroidal effusion, which is present bilaterally. And think of all the drugs. Commonest drugs are sulfur group of drugs. So apart from the antibiotics, think of the acetazolamide, which is a sulfur group of drug, which we normally use, also can cause this problem. Topiramate is a commonly used drug, which is an anti-migraine drug, anti-epileptic drug. It's like a used for multiple other pathologies by neurologists. So this is a drug that we need to think of. Also, anti-diabetics and antihypertensive drugs also can cause this. So think of a drug-induced angle closure when you see such a presentation. Unusual acute angle closure. This is again one of my patients. We were about to do a PI, but before we did a PI, what was very obvious was, you see this blood tinged hypobionc and a dirty gray color that you can see through the pupillary area. So these are a couple of findings that tell you that there is something unusual. And this patient, when we did a B scan, had an intraocular mass. So always, so typical features of acute angle closure. But if you see hypopyon or fibrin or blood tinged kind of a hypopyon, or the reflex that you see through the pupil, which is not normal, always think of a secondary cause and do a B scan to rule out a posterior segment pathology. Early postoperative rise in intraocular pressure in patients coming to the emergency again is not uncommon. I just put up a few pictures which are representative. Post-vitreoretinal surgery with oil blocking the pupil in a phakic eye. In a phakic eye, we don't normally, the vitreoretinal surgeons don't do a surgical PI, but this can happen. If you see, this beautifully looks like a crystalline lens, but this is actually an oil bubble blocking the pupil on day 1 post-op of a patient with post-VR surgery, pupillary block because of a DSEC and a large air bubble in the anterior chamber, or malignant glaucoma following any of our glaucoma intervention is something that we need to think of. Crystalline lens, which is dislocated or subluxated, or trauma. A commonest cause of unilateral angle closure in a young patient, always think of trauma and a subluxated lens that or a vitreous in the pupillary area that is causing a pupillary block. One more case, again, a young patient was referred for a YAG PI, again unilateral angle closure, but just see the eye, it is so congested and the patient had severe pain. Patient was actually started on pilocarpine and referred to us for a YAG PI. A B scan and ultrasound biomicroscopy will help you to understand. Patient had thickening of the sclera and a posterior B scan showed a posterior segment elevated lesion, and we dilated the patient, did not do a PI, and you can see a huge mass sitting there at the posterior segment. This patient also had, you can see the hypertensive retinopathy changes. Patient actually had COX and was a very, very high hypertensive, and patient had to be started on medication. So don't do a PI. You may actually be dealing with a life-threatening situation and you could be the first to diagnose a condition here. When you have an open angle, when do you suspect secondary open angle glaucoma? Majority of the time, the features are very typical. So you have a trauma, you could have history of steroid use, you could have multiple other things, post-surgical, these are the things that we think about. So I wanted to share a couple of cases which were very, very, for me, it was something that I learned from these patients and hence I wanted to share. A 17-year-old girl studying 12th standard, this was a year ago, was preparing to be a doctor. She complained of headache and blurring of vision, and she was, as usual, told that she was overexerting and because of which she had this headache, and said, okay, take an opinion from a eye specialist. So she came to me and her vision in the right eye was 20/40, left eye had less vision and pressures were very high. So the first thing that will come to your mind with no other pathology, no history of use of drugs, no nothing, is a juvenile open angle glaucoma. And while we were asking a couple of more questions, they just asked her, are you using any skin cream? She said, not much, but I just use one cream that I use at night, and I've been using that for the past 2-3 months. Because of a lack of sleep, I'm developing these black eyes, and hence the doctor, somebody advised her to use this medication. She was using a cream like this. When I went upon the internet and checked, there was a steroid content in this. There was actually nothing, and in these contents that tells you that there is a steroid. Okay, this looks so innocuous and there is absolutely no problem. But I was not happy with it. I went back and re-looked at what was there. I'll come to that, what was there in that drug. And one more patient similar to this, a 21-year-old who's an engineering student, came, similar kind of findings, and he was using another cream called Pfizer Care Cream, which again is a beauty cream. And when you go back and look at the contents, there is absolutely no mention of the steroids. But this particular one is actually banned in Pakistan when I went and reviewed the literature. And the first cream, also the pearl cream that I showed you, as well as the second cream, I'm just giving you names because these are looking so innocuous. So unless we know that it's a betnovite or some kind of a skin cream where you have a steroid in its content, we suspect a steroid-induced glaucoma. But beware that none of these creams that are available today, if you see the contents, don't be happy with it. Go back and check. And when I checked, this particular drug, this pearl cream, was intimated by the Dermatology Association to the drug controller. They checked, they found high contents of steroid in it, and they have actually filed a case in the court. Despite that, this is a picture that I took yesterday, and this is available on the internet. Anybody can buy it. So in India, I think we need to be very, very careful about the fact that we have lots of these drugs that are available in the market. Many of the young people are losing eyesight because of this. So we need to be very, very careful. First of all, understand the cause and try to treat it, but we need to take it up to the higher authorities to try and ban these drugs permanently that are available in the market. So the other group of patients that we typically have secondary glaucomas, which we may be losing eyes, is post-cataract surgery. This is an example I wanted to share because there was a lot of discussion going on in the glaucoma group recently about multifocal IOL. A patient who had a multifocal IOL in the bag had a lot of pigment dispersion and had very high intraocular pressures, and they were not understanding why this was happening, and this patient was referred to us. If you just see, this is a multifocal high magnification view. This is in the bag I'm talking about, but one area there was a irregular rhexis with a fusion of the rhexis margins with the tilt of the edge of the intraocular lens, and that was causing rubbing of the posterior surface of the iris with pigment dispersion. Okay, this patient required a IOL explantation, and we had to place a 3-piece lens in the bag, and post that her pressure started coming down. So why I wanted to share this is that just because we have an IOL in the bag, it doesn't mean that this complication cannot happen. Although rare, we have published this, but this can happen, especially if the edge of the intraocular lens is tilted, especially if you have fusion of the capsular bag, and that tilted square edge designed lens can cause pigment dispersion, and that can cause uncontrolled intraocular pressure, and that needs to be treated appropriately. So they can present variedly. You can have an obvious tilt like this. You can have a broken intraocular lens placed in the sulcus that can cause pigment dispersion, which was explanted. And this patient, again, because if a small portion of the haptic was broken, we shouldn't take a chance. We always have to make sure that this is taken care of. Otherwise, we may end up having to replace the lens at a later time point. Another situation, this is again a very interesting case of ours that we were treating. This patient had an, again, in the bag intraocular lens, a Sion type of a design lens that was placed many, many years ago. Patient came 10 years later saying that patient had a decrease in vision and recurrent redness. This patient was treated as uveitis in our institute, but this patient would come back again and again. Inflammation comes down, you put them on steroids, anti-glaucoma medications. So this process was repeating for a couple of months. When one of the cornea consultants decided that we need to take an opinion and we need to see why this is recurrently happening. So when I did a good gonio for this patient, I don't know if it is clear, but you can actually see blood in the angle. So what had happened was the rhexis was intact, but the equator of the lens had broken and the haptic of the lens had gone through the equator and was eroding on the ciliary body area. And on a dilated gonioscopy, you can actually see blood in the inferior angle. So we need to pick up the reasons whenever something like this is happening. And this patient actually needs clipping off of that haptic. Otherwise, this is going to be recurrent and we may lose the eye in a period of time. Same way, many times people say that, okay, there was a small tear in the rhexis. I don't think that's much of an issue. A hydrophobic intraocular lens is placed in the bag and your haptics are aligned well, there is no issue. But if it is placed in the sulcus, beware, you may not see a problem now, but it will come back to you or may go back to someone else many years later. So this can happen as early as in a month post-surgery, or it can happen many years after surgery, where we may actually be losing the vision for the patient slowly. And if this happens in a glaucoma patient, one needs to be even more careful. And so this is a sulcus placed lens. So what is the property of this intraocular lens that causes this problem is something that I thought I should share. So you see, this is a very sticky lens. Instead of sticking to the capsule when it is placed in the bag, it sticks to the iris when it is placed in the sulcus. So this is again a beautifully done rhexis because of a small pupil in an angle closure glaucoma patient one night. Somebody had placed this lens in the sulcus. You can actually see this is a sulcus placed lens. On retroillumination, you can see a beautiful rhexis. Uncontrolled intraocular pressure, patient was referred for a trab. All we had to do was went and opened up the bag and placed the lens in the bag, and now pressures are controlled medically only. So we need to be careful about these. So they can present in a various ways and at various time points. Could be tilt, decentration, excessive mobility, reversed position, multiple things. What are the signs that tell you that this patient has had no PC rent I'm talking about is basically excess pigmentation in the angle and iris chafing that you can see on retroillumination. Why does this happen? Because of the square edge design. To prevent the edge glare, these edges, if you see, are very rough. And that is the reason why this particular problem can happen. A 3-piece intraocular lens is something that can be used in these patients. So it is definitely a serious issue, and careful in the bag placement is very, very important. Avoid placing hydrophobic lenses in the sulcus. If you have to place it, use a 3-piece intraocular lens, because the 3-piece intraocular lens has a posterior angulation of 10 degree that will prevent its contact with the posterior surface of the iris. Plus the rounded proline haptics that are there are less damaging to the posterior surface of the iris. That is why we use a 3-piece intraocular lens. It could be a foldable one or a non-foldable one, but whatever it is, don't use a square edge design lens in hydrophobic lenses in the sulcus. So the status of the management, again, I'm not going to the details, but they depend upon how early it is. If it is very early, just by placing the lens in the bag or exchanging it would help. If it is at a later date, all these may not help. One may require to do a glaucoma surgery. So to summarize, secondary glaucomas are not uncommon. They can be sight threatening and somebody can lose the eye in a very short time. What is very important is detailed history. Meticulous history taking is very, very important. Sometimes we may need to probe and take history and meticulous clinical examination. Sometimes we may not be able to diagnose it at first visit. We may need to see the patient back second time, third time by the time you actually come to a diagnosis. Ascertain a cause and treat it appropriately. When in doubt, always do a gonioscopy. Gonioscopy is of course mandatory. Do a UBM and B scan when indicated. Think of common conditions and treat them appropriately. Sometimes we may need to think out of the box and we may have to deal with the uncommon causes and treat them appropriately. Thank you for your attention.
Thank you so much, Sirisha. Wonderful presentation. And I think you have covered a whole lot of things, but I'm sure that the secondary glaucomas goes beyond. But we can present only this much in 15 minutes time. I hope all the PGs and other practitioners also are watching this program to understand how many secondary glaucomas we can have and how to really go and investigate what is going on for them and treat the cause, as I mentioned earlier. So we'll just have more discussion later. Now I would like to introduce Dr. Manish Shah. He's a director, Foresight Eye Center and Glaucoma Clinic, and he's a consultant at Lilavati Hospital in Mumbai. He was the past treasurer of Glaucoma Society of India, and he has an experience of over 22 years in glaucoma. He's going to talk to us on non-responding cases and treatment options for that. Before Manish uploads his slides, just have an announcement. We have the quiz program after Dr. Roni's talk. So all of you, please prepare yourself for the quiz program as well. Over to you, Manish.
Thank you, Dr. Satyan, and thank you to CIPLA and to the AIOS and Lalit Verma for giving this opportunity to share some of the cases of non-response. And that would be, so we have got, this is a whole presentation is just a few cases, and there will be some, I'm going to skip over things which have already been talked in extensive time. So the first case is a 60-year-old male who reports with complaints of heaviness, strain in dim light, has a family history of glaucoma. Some years back, he had an episode of ischemic heart disease and arrhythmia, and he's on treatment for that. Vision is 6/6, N6, anterior segments normal, but IOP is on Goldman applanation 28 in right and 35 in the left. Gonioscopy showed appositional closure with left eye showing some synechias in 2 quadrants. So this is the, quickly I'm just sharing the disc appearance as well as the OCT image, which shows in the left eye there is a superior nasal, superior nerve fiber layer defect, and which is represented with an inferior field defect. So as we always do, both eyes YAG PI was done, and right eye after the PI there was a good opening, but left eye the opening was not that good because, and there were synechia present which we had already seen. So because of the residual pressure, it was already started on a prostaglandin analog, with which the right eye pressure came in the range between 14 to 17, and the left eye came to a range of 24 to 28, which obviously we were not very happy with the left eye pressure level on a single drug. Therefore, we wanted to add something, but because the patient has arrhythmia in the past, we did not want to use a beta blocker. So the preference was given to additional of dorzolamide, with which the left eye pressure came a little bit, responded a bit, but still it is not sufficient. It was fluctuating between 20 and 25. Brimonidine was briefly tried, but in a day or two only, patient was not happy with the response. So now this is a patient who has got a typical angle closure, left eye more than right eye, and you've already done one iridotomy, which has shown a response, but it's not sufficient. So now what are your treatment options? Because obviously this is not a patient who is doing very well with standard medical therapy, at least in the left eye. So the first option is addition of pilocarpine. Now, pilocarpine is a drug which is not commonly used because of its intolerance issues. But it is useful, and generally in a lot of cases where I've used it, I prefer to use it in a combination, a fixed drug combination of pilocarpine with timolol, because it seems to be much better tolerated. However, in this case, we can't use timolol. So you may want to give a trial of pilocarpine alone. And since the patient is 60, younger patients and myopes, you would like to avoid pilocarpine. But in this case, we can try pilocarpine. And now we have a new kid on the block, which is the new group of drugs of ROCK2 inhibitors. And I have some limited experience with these drugs. And I think ripasudil is one of the drugs which I probably would consider trying. Other options which are there before us is, the very extensive reports were there about clear lens extraction in angle closure patients as the primary treatment. Well, we have seen the study, but we are not yet very convinced of doing it in all patients. But here is a situation, 60-year-old patient who is already having some amount of angle closure, and our PI is not able to restore the angle, nor is the pressure controlled. Is there a role for doing an extraction of the lens? Is the question which a lot of people would like to ask. And yes, there are people who would probably think of that as one clear solution, but I would not be in favor in this condition, because there is already synechiae present, which indicates that the trabecular meshwork has already taken some amount of damage, and removing the lens probably is not going to give us what we want. Laser iridoplasty is one more additional procedure which may be tried. And I know Dr. Harsh, who is on the panel here, is having extensive experience with this procedure, and probably in the panel we can discuss this. But I have limited experience and seen it work in some situations, but usually in patients who don't have synechiae present. So I would say the best option in my hands would be to consider this patient for trabeculectomy with mitomycin C, as the patient doesn't have any other problem with that. Now, this is the second patient, who is a 68-year-old male, again having a history of asthma, presented with a right eye pressure of 23 and left eye pressure of 27 on timolol OD. So you have a patient of asthma, and you are not going to usually use timolol in this patient. Pachymetry 510, left eye 522, angles open, and here is the situation where the visual field is there. Nasal defect with the inferior nerve fiber layer defect, and this eye has a deeper inferior nerve fiber layer defect with a larger superior defect, and you would like target intraocular pressure of right eye 17 to 20 and the left eye 14 to 17. Here, as I said earlier, we have to stop the timolol because it is contraindicated in a patient with asthma, and therefore we opted for prostaglandin, that is latanoprost, and obviously we would prefer to start with a monotherapy. So right eye with the monotherapy of latanoprost, we got right eye pressure 16 and left eye pressure of 18. Now, this is not still reaching what targets we would like to achieve. So what are the options? The options, as pointed out earlier by earlier speakers, in this situation, you would have to add either a carbonic anhydrase or a brimonidine to the left eye. Or you have the other option of switching to another prostaglandin analog. At this point, I would like to make it well understood that when you have a not adequate response or a poor response with one prostaglandin, it makes scientific sense to switch to another prostaglandin, and there is likelihood that another prostaglandin would give you the desired outcome where one could not. So I am in favor of actually trying to see if one of the other prostaglandins other than latanoprost would be able to give us the result, rather than going for multi-drug therapy in this kind of a scenario, because you just want a little more reduction in pressure, maybe 2 or 3 points. As some discussion was already there on The laser therapies, and as we discussed that almost we are now not doing ALTs but doing SLTs. In an open angle patient, getting 20% reduction further with an SLT is a very possible solution. And I would say in this scenario where the patient has asthma and you are started a medical treatment which has not been a long time, treating with SLT may be a very good option, and you would probably get the result you desire. Of course, there are options of doing non-penetrating glaucoma surgery and other angle surgeries such as a trabectome or implants in the angle, and all these are usually done when you combine surgeries with cataract surgery and not done as standalone procedures. The gold standard, however, of surgical procedures is a trabeculectomy with mitomycin. Some people like to use an express shunt, but I would still say when surgical option is desired, I would select a trabeculectomy with mitomycin over everything else. The third is an interesting patient, is a 16-year-old boy referred for uncontrolled IOP in the right eye with all the medications. The vision shows right eye already reduced 6/12, left eye with correction is 6/6. On maximal treatment, which includes 4 group of drugs, the pressure in the right eye is still 28 and left eye is 13. The right eye gonioscopy shows a lot of pigmentation, however, no synechia are seen. Left eye is open with average pigmentation. Visual fields in the right eye showed a very narrow central field only on the 10 dash. However, the left eye did show some superior aqueous defect. The patient was of the patient, which is the most important data I would like to share. And as you can see on the superior side, you have an ectatic lesion in the sclera with the scleral thinning, and you cannot probably think of doing a trabeculectomy at that location. So what about the use of mitomycin? Because a young 16-year-old with a past history of uveitis, so you cannot probably do any trabeculectomy without an anti-scarring addition. So what would you like to use? Because I would not be comfortable using mitomycin in this case. So what are your options? If you do a trabeculectomy, what about the antifibrotics? I would not be in a comfortable position to use. One option where the antifibrotic part can be taken care with an Ologen implant is one option which we can consider, and to share with you, that is exactly what I did, and the patient responded beautifully to Ologen implant, and this surgery was done about 7 years ago, and he's still very well controlled in that eye. The other option which I contemplated is putting an Ahmed valve as primary, because he has had past history of uveitis. I was worried that all trabeculectomies will have a shorter expectancy of survival because of recurrent uveitis, and we didn't know, but in such a young patient, putting an Ahmed valve directly, which is known to over time have an impact on the endothelial cells, was not an easy decision. Second thing, putting the Ahmed valve in that location where sclera is thin is also not a good idea. So I would have to actually put a scleral graft and then put the Ahmed valve. So this I avoided, but I would be happy to do it if the first surgery fails. Coming to the next case is a 58-year-old male who did complain of blurred vision, but vision was 6/6 and 6 with a myopic of -7 correction. Both eyes anterior segments were normal. Right eye pressure was 17, left eye pressure was 15. Tachymetry was average. Gonioscopy did show an open angle. I will show you the disc and field shortly. We did a diurnal variation for this patient, and we did not find any reading about 21. He was on systemic hypertensive medication with an ACE inhibitor in the morning and quite well controlled. History did not reveal any steroid use, trauma, past history of shock, and he did not have any diabetes. There was no significant family history of glaucoma, and this is the picture of his optic nerve, which clearly shows the right eye to be much more affected than the left, but both are showing significant damage. And the right eye on the first visual field itself showed very advanced damage. The left eye also showed severe damage. And this patient was initiated because it was diagnosed as a normal tension kind of glaucoma and was initiated on prostaglandin therapy, with which he responded, and the pressure came down at least 3-4 points to 12 and 13. He was kept under observation and repeat fields. He was very compliant with follow-ups, and therefore I assumed quite compliant with the medical therapy itself. But as time went, the right eye did show consistently some amount of progressive damage. Left eye continued to do well. So we enhanced the right eye therapy with dorzolamide and brimonidine. The left eye continued with prostaglandin, but as per the previous discussion, we still added dorzolamide there because of the concept of the dysregulation of vascular flow, which was assumed because we were not able to show anything on the flow tests. The right IOP showed fluctuations, sometimes going up to 19. The left eye IOPs were much stable and the fluctuations were not much, going up to 14. Therefore, we then decided to do a mitomycin trabeculectomy in the right eye. After the trabeculectomy, also consistently over the next 3 years, he did show progressive damage, and this is only on the 24-2, but also on the 10-2, which was also done consistently. There is evidence of some slow progression which is going on. And as shown by other speakers earlier, this does happen sometimes, and IOPs were quite stable in the left eye between 10 and 14. Right eye, even after the trabeculectomy, we still gave him prostaglandin and dorzolamide and maintained his pressures sometimes to single digits, some maximum going to 13. But still, if he is showing progression, what are we going to do? We did the carotid Dopplers with whatever technology we had. As Dr. Murli pointed out, there are more skillful tests and skillful operators who can get us more data, but whatever we got was not contributory. The BP halter was also not conclusive. We did the sleep apnea test at home, which showed the index to be somewhere around 14, and that is just a little bit here or there, not really showing very sure defect. The MRI showed optic nerve atrophy, which very commonly is seen, especially in the right eye, but did not add anything further. So this is one of the cases where we are really at the end of our brains to do what we can do. So give him curcumin, coenzyme Q10, vitamin B12, acetylcholine. One important aspect which came into picture in this particular patient after going into a lot of history was that he always preferred to sleep laterally in the right side only. And there I did find some references that this could be a reason of continuous progression on one side, and we corrected that, and he did stabilize. In the last 3 years, his right eye has been now stable. This is the 5th case of a 64-year-old male who again reported for routine eye examination, well-controlled diabetes, but non-hypertensive. Vision was 6/6 and 6, but IOPs were high, right eye 26 and left eye 24 with open angles. The disc and the fields were as shown. The right eye showed a defect which was superior and very close to fixation, the sign of defects which we commonly see in normal tension glaucomas and in optic nerve anomalies. The left eye showed a little bit of a cluster in the nasal field. Now here is the optic disc, the right eye optic disc clearly showing a tilted optic disc with a large area of temporal crescent, and we don't know whether this is an optic disc anomaly producing this defect, but as the pressures were high, we have to treat. The left eye also is a bit tilted, but definitely much less than seen in the right eye. So we started initial medical therapy with latanoprost. But this was a real surprise. Patient reports back in 15 days with very, very uncomfortable sensation of foreign bodies, redness, and even fluctuating vision. And this is what we found on examination is the lot of punctate keratopathy and the posterior blepharitis be acting up over here. So this is a patient who is definitely with the either because of the drug or because of the preservative, and there must have been a little dry eyes initially, which I had missed because posterior blepharitis, sometimes you don't see that carefully and it is missed, and it got exacerbated with the medication. So what are the options you would have in treating such a patient and getting out of this situation? Of course, we have now in the last 2 or 3 years, a lot of preservative free or alternative preservative medications, including totally preservative free medications and lubricants. So I would definitely take up on this. Besides the treatment of the blepharitis also has to be done. keeping in mind that steroid creams should not be used or used very sparingly. The second option, as we had discussed earlier, is to do a SLT. This is a treatment naive patient with early glaucoma. However, since the right eye shows a field defect which is close to fixation, he should be classified a little more than just mild, but definitely he should respond very well to SLT, because this falls in the category of the best responders to SLT treatment. So I would say using SLT would take away from all medical treatment. Then there is the option of doing a non-penetrating glaucoma surgery, which also is likely to give good results in this patient. And however, if everything, that would be a little far call to do a trabeculectomy. We would generally like to keep this after we have observed the patient for some time and see how he responds to our non-surgical interventions first. So thank you very much for your time, and thank you for the opportunity.
Thank you, Manish. That's a wonderful presentation. You have discussed many of the non-responders, and it is not that easy for us to treat the non-responders, identifying the cause and kind of changing this medicine to that medicine, and then finding out what can work for them, and then doing the surgery and what type of a surgery. It's not that easy. So if you have some amount of experience, then probably you can tackle these patients much better. And I think your presentation has helped to an extent to our audience today. Thank you, Manish. Now we'll have the last presentation from Dr. Roni George. Roni is the Deputy Director of Glaucoma Services at Shankar Nethralaya. He is one of the, again, very, very soft-spoken persons like Harsha Rao. Many times we had to go very close to him to hear what he is saying. Such a nice person, and he has many awards to his credit. And of course, we are going to hear from Dr. Roni on tips to avoid and tackle the surgical complications. Many of us do have the surgical complications. Let's hear from Dr. Roni. Over to you, Roni. Roni, I would request you to speak a little louder so we can.
Thank you. Yeah. Am I loud enough, and can you see me?
Yeah, you are loud.
Nice. Thank you, Satyan. Thank AIOS and Dr. Lalit Verma for the kind invitation. So like Satyan said, not most of us, all of us as glaucoma surgeons will have complications. And I'm just going to deal with just 3 complications. Since we're running a little late, I'll try and finish it up a little early. And they're basically a bleb leak and overfiltration and a dysesthetic bleb. So a bleb leak is fairly common after glaucoma surgery. And it can happen at the wound edge, and therefore it's definitely much commoner among phonics-based flaps. Or it can happen because you have an undetected buttonhole during surgery. Or it can happen because your conjunctiva gives way post-operatively. And it's of course most common whenever you use a antimetabolic. You can also get it late in localized thin cystic blebs. So if you look at a bleb like this, unless you actually take a look, you're not sure whether this is leaking or not. You also, if you have signs of a low intraocular pressure or a shallow anterior chamber or a shallow or a flat bleb with near normal pressures, you should suspect a bleb leak. And you should do a serial test for that, which is basically you paint the area of the bleb and you look to see whether you're seeing any leakage of aqueous. Sometimes, so this is a situation where there's a relatively early post-op and you're seeing not much of a bleb, but the pressures were 12. And you can see that there doesn't appear to be too much of a leak. But the moment I start massaging, you can see a little fluid come there. So this is somebody who, because the pressures are low right now and there's not much of a bleb, you're not seeing a leak. But the moment you massage, you're actually seeing a fairly significant flow of aqueous. So this person was about 6 days post-op, and he was one-eyed, and therefore we did not want to pressure patch him. We just used a large diameter bandage contact lens, switched the steroid to something which is not a suspension, and within about 4 days, that edge leak healed and he developed a good bleb. If it's going to take longer than that, you can also consider using oral doxycycline that helps the epithelialization. And if it takes even longer than that, then suturing of the defect is an option. Some of us also like to use aqueous suppressants at this point. The theory is that when you reduce aqueous production, it reduces the pressure gradient across the trap, and therefore the scleral flap opposes to the scleral bed. But this early post-op, I don't really like to use it because it can cause your bleb to fail. What happens if you have a late leak, which is also anterior, like in this patient? This is about 8 weeks post-operatively, and you're seeing a fairly brisk leak there. These eyes are very difficult to suture because by now this conjunctiva is very thin anteriorly. So here again, you would try using the same conservative methods that I just outlined to you. But if you have something like this, and this is a patient who's about a couple of years post-op, and you're seeing a leak there, this is more posterior. Here again, you can try observation and aquasuppressants. You can try bandage contact lens, but you have to make sure that the edge of the lens is well away from your leaky area. You can try patching and you can try lubricants. If you try this for a week or two and you don't really get much of a benefit, then you may need to try in terms of trying to repair it. You have two options there. You can try autologous blood or you can try blood revision. With autologous blood, you may be about 60% likely to be able to sort out the leak, but it can recur. With a blood revision, obviously that's definitive. So this is somebody whom the first step is on table, try and isolate, locate the leak. And you can see that it's diluting over there. And this is a bleb revision here, which is being done for a leaky bleb, which is there. And you can see that it's a small localized cystic bleb. So it's important that you excise the bleb area and you excise that tissue, because when you excise that tissue, you get rid of the epithelium covering this. And after that, you have two options. One option would be to either do a conjunctival advancement where you pull this conjunctiva down, or you could try and do a patch graft, which is actually what has been done in this case. So the patch graft is typically taken after you undermine the area around the bleb so that you do not get scarring. You measure it and you take it from a quadrant where the conjunctiva is healthy and you bring it up and you can suture it typically with interrupted or continuous sutures. So in the interest of time, I will go on to the next slide. And the other option that you have is when you have a slightly overfiltering bleb with a small leak is to try and induce scarring. You can use autologous blood injection or compression sutures or both. If there is a really large overfiltration, you may even need to use a scleral patch graft. So I'm going to share with you this patient who basically was hypotonous and he had a little leak over here. His IOPs were consistently 4 to 5, young juvenile onset of glaucoma with fairly severe disease. So we did not want to revise the bleb and induce failure. So what we have taken is we have taken blood from the antecubital vein. You can see that there's some amount of blood filling the bleb and also some filling the eye. So it's important that you tell these people that you might have blood in the eye, you may have blurred vision after that. Also remember that if you're using a 26 gauge needle here, it's important that you don't use a very fine 30 gauge needle because that can hemolyze the blood and that will not help you to set up a fibrotic reaction. So one of the advantages of autologous blood is it's a relatively innocuous technique, pretty easy to do, not very successful, but in this patient at least 8 years down the line, we still have pressures of about 8 to 10 and he has a preserved visual field. This is one of those rare complications of with a large overhanging bleb that you can see. And this is more common with the limbus-based trabs. And this type of thing is actually fairly easy to deal with. And you can do it in two ways. You can use compression sutures after excising it. And the compression sutures are typically taken in this reverse X method, or you can take it as two parallel lines. So this type of, so this was somebody with just an overfiltering bleb where we put down compression sutures, and you can see that the 3 sets of compression sutures did fairly well in reducing intraocular pressures to a reasonable level. So this is a slide which I have taken from Dr. Arun Narayan Swami, and you can see over here that this was an overhanging bleb. You can easily peel this off. It just comes off very, very easily. And then you can just cut it. And it will not leak. For those of you who have ever opened up a bleb post-operatively, you will notice that most blebs are actually loculated, and therefore you will not actually see an edge leak. And he'll demonstrate it here and show you that there is really no leak there. So this is also combined with a compression suture. These type of blebs can be very dysesthetic. They can be very uncomfortable to the patient because they're overhanging, and every time you blink, it becomes uncomfortable. So here the decision was taken to take compression sutures. And compression sutures, you basically take a 10-0 suture, you take it through the clear cornea, and then you pull it back to posterior to the bleb area. Ensure that you reach bare sclera and take a bite through the bare sclera. Then you tighten the suture once you take a breath. So this is fairly effective. And if there is a significant component of overfiltration in addition to the dysesthesia, it's worthwhile to give an autologous blood injection too. So typically always do the compression suture first and then give the blood, because otherwise your view can be pretty bad and you can struggle to close it. So here you've taken one, you can take 2 or 3 sutures depending on how many you require. So this is the same patient at the 10th post-op day. You can see that the cornea is epithelialized completely. There is some amount of scarring there, and the blood has come down significantly. So how do you prevent these complications? And that's really important, because nowadays we treat everybody with mitomycin most of the time when we're doing surgery. The 3 important things to remember are: ensure that you treat as large an area as possible with mitomycin, depending on your conjunctival opening. Close the conjunctiva meticulously and ensure that there is no edge leak on table. And I'll show you basically what I do. So this is somebody who's already had a trab here. You can see that there's a trab here. And I'm doing a retrab in this quadrant. So that's the amount of conjunctiva I've opened up, but I've dissected posteriorly, and you can see that I'm putting these, my mitomycin pledgets in a fairly large area. The advantage of the large area is that when you get fibrosis of the bleb, it occurs sideways. And this will keep compressing the bleb area till you'll end up with a small stretched cystic bleb like this. So by treating a large area, you're reducing the risk of this sort of scarring happening. And these are the type of blebs which finally end up leaking or even with a blebitis. So when it comes to conjunctival closure, so it's important here, notice that you have to close the conjunctiva completely and see, if you don't look for it, you might miss the tenons. So you have to close both together or separately, but ensure that both are opposed to the limbus. And what you will also see over here is, so what I typically do is I take 2 wing sutures and I take a mattress suture in the center. There are many different ways of doing it. I'm just showing you what happens here. So in this case, I'm incorporating that dog ear there by taking multiple bites in a concertina-like fashion. And I'm taking my suture out through the edge of the section so that I can bury the knot. So basically this type of a wing suture will help you to pull the conjunctiva down, but make sure you've got your tenons also along with it, and that you are tighten up. You place a similar wing suture on the other end. I also like to take a single suture here, and what you will see here is a mattress suture, which I'm taking through a clear cornea. Then I take a bite out through the edge of the conjunctiva. You have to be very careful over here so that you don't take multiple bites. Just take one bite, otherwise this edge can leak. And then you go back through the conjunctiva there. And notice here that at this point, it's important that you assess the pressure in the eye. And notice here that I'm refilling the chamber so that the globe is fairly firm, so that when I suture it, I get appropriate tightness. If you try to suture it when the globe is soft, you will actually tighten it too much and you will get fish mouthing here and you'll actually get a leak. So it's important that you assess this carefully and that you tie this carefully. And possibly the last step that you need to do is ensure that there is no leak. And this is the first retrap that I showed you. So you can see I'm checking carefully. I'm especially checking this edge because this is the area of the previous trap, and this is where the closure is likely to be most inadequate. And you have to make sure that there is no edge leak at the end of surgery, because if there is an edge leak at the end of surgery, you're very likely to have a leak even post-operatively. Even if there's no edge leak at the end of surgery, you might still have leak, but you at least made sure that it is not there when you started. So in summary, when it comes to a conjunctiva, look for a leak even in the case of a slightest doubt. Conservative management is very often effective even very early in disease. There are multiple surgical options that you can use in order to try and minimize complication rates and also to maintain bleb function. But don't forget that prevention is better than cure, and meticulous closure is what is probably more important than any of the post-operative interventions that you can do. Thank you.
Thank you so much, Ronnie. Thank you for your presentation. And I think you have covered at least a few of the major problems which we have in the trabeculectomy. So before I have the discussion, I'm going to the quiz. I would request all of you just take a notepad and a pen, and you can write down all your answers. So prepare your notepad and pen. So can I have the quiz time? Yeah. So we have some rules, and can you just show me the rules? Yeah. So this is the old slide. I'm sorry for this. So we have actually 15 questions, each with 4 multiple choices. Please note down all your answers in the notepad in the sequence asked. Please don't post any of your answers at this stage. Just hold on. Just keep writing your answers in your notepad. At the end of all the questions, we'll give you at least 2 minutes so that you can post all your answers. Please see in your screens, please see there is a tab called Ask the Expert. That is the area where you have to post your answers on your screen. So the example is given, just see the below the note, there is an example of answer. The correct answers out of all the 4 multiple choices, you just write the correct answer, D, C, B, or whatever the answer is. This is not the correct answer. Don't copy this and then put it in that into the question thing. So we have 2 winners. The winners will be announced once the panel discussion is over. It will be a cash prize, and we'll discuss the answer at the end of the panel discussion. So we'll have the questions. So all of you ready? Yes. So we have the first question. The question number 1 is, if you have just listened to all the speakers in the presentation today, most of you can answer correctly all the answers. So the question number 1 is, color Doppler imaging measures flow velocity in A, retrobulbar vessels, B, choroid, C, retina, D, all of the above. I'll just repeat it. Color Doppler imaging measures flow velocity in retrobulbar vessels, choroid, retina, all the above. Got the question number 2? Yes. We have the question number 2. Increase in ocular blood flow is seen in most clinical studies with A, PG analogs, B, timolol, C, carbonic anhydrase inhibitors, D, rho kinase inhibitors. I'll just repeat one more time. Increase in ocular blood flow is seen in most clinical studies with PG analogs, timolol, carbonic anhydrase inhibitors, rho kinase inhibitors. Go to the next slide, please. Yeah. The question number 3, best tool to evaluate optic disc in glaucoma. A, OCT, that is optical coherence tomography. B, Heidelberg retinal tomograph. C, OCT angiography. D, stereoscopic disc evaluation with high plus lenses. One more time, I will repeat. Best tool to evaluate optic disc in glaucoma. OCT, Heidelberg retinal tomograph, OCT-A, stereoscopic disc evaluation with high plus lenses. We'll go to question number 4. Most important finding indicating non-glaucomatous causes of cupping. A, Brand's hemorrhage. B, violation of Isint rule. D, C, optic disc pallor. D, alpha zone peripapillary atrophy. Just repeat. Question number 4. Most important finding indicating non-glaucomatous cause of cupping. Brand's hemorrhage, violation of Ising rule, disc pallor, alpha zone PPA. Next question. Question number 5. What are the vascular risk factors in normal tension glaucoma? A. Diabetes. B. Migraine. C. Systemic hypotension. D. Flamer syndrome. E. All of the above. Repeat. Question number 5. What are the vascular risk factors in NTG? Diabetes, migraine, systemic hypertension, Flamer syndrome, all of the above. We go to the question number 6. Question number 6. The first line treatment of NTG is A. Beta blocker, B. Prostaglandin analog, C. Carbonic anhydrase inhibitor, D. Alpha agonist. I'm just repeating one more time. This is just giving you time for you to answer. So question number 6, first line treatment of NTG is beta blocker, PG analog, CA inhibitor, alpha agonist. Question number 7, which of the following is not true regarding glaucoma progression? A. It is important to look for both structural and functional progression during follow-up visits. B. All glaucomatous eyes progress if examined frequently enough and long enough. C. Using some type of statistical analysis software is preferred over clinical judgment method to better detect glaucoma progression. D. Both visual fields and imaging methods suffer from similar levels of floor effects. Just to repeat the question, it is a little long answers for this. Which of the following is not true regarding the glaucoma progression? It is important to look for both structural and functional progression during follow-up visits. All glaucomatous eye progress if examined frequently enough and long enough using the software. And both visual fields and imaging methods suffer from similar levels of floor effects. Going to the question number 8. Next question, please. No. Go to the question. Yeah, thank you. So question number 8. What is not true regarding progression in advanced glaucoma? A. It is challenging to detect progression in advanced glaucoma. B. Visual fields are preferred to imaging methods in detecting progression in advanced glaucoma. Peripapillary RNFL is preferred over inner retinal thickness measurements at macula for detecting progression in advanced glaucoma. None of the above. I'll just read it one more time. Question number 8. What is not true regarding progression in advanced glaucoma? It is challenging to detect progression in advanced glaucoma. Visual fields are preferred to imaging methods. Peripapillary RNFL is preferred over inner retinal thickness measurements. None of the above. Go to question number 9. What percentage of patients with exfoliation likely to develop glaucoma? A. 10 to 20, B. 20 to 40, C. 40 to 60, D. 60 to 70. Just to repeat the question. Question number 9. What percentage of glaucoma patients with pseudo exfoliation likely to develop glaucoma? 10 to 20, 20 to 40, 40 to 60, and 60 to 70. Question number 10. Which glaucoma phenotype is known to progress than others? A. POAG, B. Exfoliative glaucoma, C. NTG, D. Steroid-induced glaucoma. Question number 10. Which glaucoma phenotype is known to progress than the others? Faster, okay? So POAG, exfoliative glaucoma, NTG, or the steroid-induced glaucoma. What is question number 11? The question number 11, which of the following gene mutations are associated with exfoliation glaucoma? Optineurin, A, optineurin, B, CYP1B1, C, PLEKHA7, D, LOXL1, C, NT-NAP2. Repeat the question. Question number 11, which of the following genes and gene mutations are associated with exfoliation glaucoma? Optineurin, CYP1B1, PLEKHA7, LOXL1. We'll go to question number 12. Yeah. Question number 12, OSD in glaucoma patients. Which of the following are likely to contribute? BAK as preservative in eyes. That is A. B, the active component of the drug. C, mitomycin used in glaucoma surgery. D, excessive screen time. Just to repeat the question. Question number 12, OSD in glaucoma patients. Which of the following is not likely to contribute? Just repeat one more time. OSD in glaucoma patients. Which of the following is not likely to contribute? A, BAK. B, the active component of the drug. Mitomycin used in glaucoma surgery. Excessive screen time. Question number 13. Patients with angle closure glaucoma, that is 1 PI done, with poor control on medical therapy. Which of the following would be the next step? A, non-penetrating glaucoma surgery. B, trabeculectomy with MMC. C, SLT. D, repeat YAG iridotomy. Just to repeat, patient with angle closure glaucoma, 1 PI done, with a poor control on medical therapy. Which of the following would be the next step? NPGS, TRAB with MMC, SLT, repeat YAG iridotomy. Question number 14. This is question number 14. All of the following can be used to treat a conjunctival leak post trabeculectomy except A, bandage contact lens, B, patching of the eye, C, oral doxycycline, D, compression suture. Question number 14. All of the following can be used to treat the conjunctival leak post trabeculectomy except BCL, patching the eye, oral doxy, and the compression suture. The last question, question number 15. Autologous blood injections can be used in all the following situations except A, small bleb leaks, B, overfiltering blebs, C, encysted blebs, D, thin cystic blebs. The last question, the question number 15, I'll just repeat. Autologous blood injections can be used in all the following situations except small bleb leaks, overfiltering blebs, encysted blebs, thin cystic blebs. So hope all of you can answer. You can start answering now. Please see in your bottom in the screen. You can see in the screen, and you can just type your answers. So it will be for 2 minutes. Please answer. Now we can go to the panel discussion. At the end of panel discussion, I'll give you all the answers. You may feel that your answer may be correct, but whatever the experts had given the answers will be the final verdict. There is no change from that. Based on that, only the winners will be announced. If more than one winner is there, then that will be seen with the who is answering the answers a bit faster. He will be or she will be picked up as the winner. So there are two winners, one winner and one runner. Over to Dr. Harsh for the panel discussion.
Thank you, Satyan. I think most of the questions are very nice because they've already covered a lot of things.
Yeah.
But let's take some of the people who have asked. Dr. Alka has asked, what should be the target pressure in NTG? So let's let Mayuri answer this. I think we have to use our panel after all. Though we could have asked the speakers, the better thing is to ask the panel now. Dr. Mayuri, are you there?
Yes, yes.
Yeah. So how should we set a target pressure in normal tension glaucoma?
Normally, the normal tension glaucoma pressure is already low in the higher teens or the 20s. So the target pressure should be somewhere in the lower teens or 13% reduction from the baseline.
And together we'll take this, although it has been covered adequately, since there is a specific question by Dr. Narendra, ki what should be the classical anti-glaucoma medication in NTG?
I prefer to use with first line of drug is PG analog. This drug can reduce the intraocular pressure less than the episcleral venous pressure.
Okay, that's short and sweet. So we can go on to Sirish, and there is a question. If there's by Dr. Gupta, if there's a mature cataract and the pressure is greater than 35 despite whatever medications we give, what is the type of surgery you would like to do and how would you like to proceed?
Obviously, when the cataract is already mature and then we have a very high pressure, I think it makes a lot of sense going for a combined surgery like phacotrabeculectomy.
Mm-hmm.
Usually it gives a pretty good result. In fact, I would feel that, compared to a plain trabeculectomy, a phacotrabeculectomy, I mean, even discounting a mature cataract, I'm giving this answer. So phacotrabeculectomy, since it deepens the chamber, you have fewer complications which are associated with the shallow AC. But specifically in this situation, a phacotrab is the answer.
So, Dr. Sumit Chaudhary, would you suppose this pressure is, let us say, around 45, and the patient and we are forced to operate? Would you like to do some? Tell them anything specific that you would like to do pre-operatively?
In this case, the gonioscopy is a very important factor because if there is a mature cataract, the lens swells up, the angle flows, and the pressure rises. So gonioscopy is very important in that time, and also the contralateral movement. If it is fine, it's ankle closer. I think that cataract with the PI for the present situation, and also look for the other, like if there is any glaucoma changes is there or not.
Okay, what I was trying to say is that if the pressure is extremely high and we are going to open up, then one has to be very, very careful because one could lead to a really big problem. Yeah, that's right.
The chance is very expensive.
Exactly.
So it would be worthwhile reducing the pressure preoperatively with good amount of anti-glaucoma.
Exactly.
Mannitol.
The problem is that he's as he's saying that even despite everything, it doesn't decrease.
No, maybe about topical medications. I think giving mannitol fast would definitely help reduce his pressure.
Okay, that is one thing. So definitely this must be very clear to all of them that they have to give mannitol. Obviously, before mannitol, you will be checked whether the patient would not go into CHF and he has no cardiac problems and BP problems. That must be checked before you give mannitol.
Usually
the second thing,
massage, sorry to interrupt, sir. Usually a good massage even pre-operatively on the table after we do a retrobulbar block or a peribulbar. A good massage also will go a long way in reducing the intraocular pressure.
Very right. So it will be a good intermittent massage because please do not put a super pinky because then by the time you remove the cataract, there won't be anything left in the nerve. And one thing I really wanted to say was that one could possibly at times go in if you have retina chap with you. Sometimes we make a core width little bit so that really helps to deepen the chamber and lower the pressure so that you won't land up in this kind of a situation. There's another question, and Rita, maybe you can answer this, that if there are significant GCC changes, but the RNFL is reasonably okay and the rest, all the things are okay, would you like to treat this patient just based on the changes in the GCC?
No, I would definitely not. I think I would depend on many other findings. Just looking at a report is not what compels me to start treatment. You're only talking about GCC changes. You're not telling me what the disc is like, what the pressures are like. So I would like to evaluate the patient as a whole before I decide that I want to start.
They are saying everything else is normal.
No, then I would definitely not want to treat this patient.
Okay, fair enough. So a very simple question by Dr. Anuradha. How frequently would you like to do fields in moderate and advanced glaucoma? Mayuri, would you like to take that?
In advanced glaucoma, if my pressure is on the target, then I will repeat it at 6 months. Otherwise, even at 4 months or 3 months, I would like to repeat with a higher pressure.
Okay, and I think Siri.
Mild cases of glaucoma, we repeat it at 1 year.
Yeah, right. So ocular hypertensives and very mild, you would like to repeat at 1 year, and the rest with very advanced, it could be even 3 months. Sirisha, you had answered a question on the chat, but can you please answer it for everybody over there so that they would know? Somebody had asked that why use that 3-piece and what is the advantage of that in putting it in sulcus?
Yeah, so the single piece lens, whether it is the a single piece acrylic lens that I'm talking about, or the square edge designed ones, so whichever company it belongs to, they are designed to be placed in the bag, and they have two properties. One is they are very flexible. They are all foldable lenses. They are very flexible and they are quite adherent. So if they are placed in the bag, and that's one of the reasons, so it decreases the amount of PCO formation, and also because of the square edge design, the surface is quite broad. So they have a lot of peripheral aberrations. To prevent peripheral aberrations, these lenses are designed in such a way that the periphery of the optic as well as the haptic is rough. They are not smoothened. Because they are rough and they are also sticky, they tend to stick to the posterior surface of the iris and cause a lot of pigment dispersion. While we may not really realize that the problem is happening in the early postoperative period, over many, many years, you see that this can happen and they can slowly lose the eye. So why we can use a 3-piece lens here? 3-piece again is a foldable lens. It has a square edge design optic, but the optic and the haptic, they have a 5-degree posterior angulation of the optic. That means it's like a reverse tripod. So you have the optic which is pushed towards the posterior capsule and the haptics are placed in the sulcus. By doing so, the edge of the optic is not in contact with the posterior surface of the iris and hence prevents pigment dispersion. So basically, what is the problem with the sulcus placed lens? It causes pigment dispersion. Second problem can be pupillary block. Leaving alone pupillary block, if you have a deep anterior chamber, the one thing that we worry about and we should always definitely worry about is the pigment dispersion in the long term. I think that clarifies.
Yeah, Sirisha, the problem is that many a times these are single practitioners and they have no backup lenses and all that.
So don't place it.
Don't place it. Good. So that's the right advice. You see, because sometimes when you are alone and you don't have anything and you can't get this lens pretty fast, then it is better not to place it and then later place it, because Sirisha has very clearly said what exactly happens with that. So thank you for that. And Priyanka, Dr. Priyanka has asked, is progression better identified by RNFL or field trends? So, Sirish, would you like to take that? Dr. Sirish, would you prefer an RNFL to detect progression? Would you like to depend more on RNFL or on field to show you the trend analysis?
Yeah, I'm putting my video off while answering because the bandwidth is, I think, not letting me put both together.
Right,
and it's creating some disturbance. So while speaking, I'm just putting the video
this voice is clear. Yeah.
Yeah. So I think Dr. Harsha, he spoke very well, and then he explicitly told in one of the slides if we want to detect progression in the early stages of glaucoma, usually the RNFL analyzers have an edge. Because we are able to assess the RNFL damage much earlier, the structural damage much earlier. And if we have serial analysis of RNFL, we will be able to assess the damage earlier. Whereas in the moderate stages of glaucoma, usually video, even in the advanced stages and the moderate stages, visual fields will have upper hand in detecting the progression without a doubt. In advanced stages of glaucoma, usually RNFL analysis almost has no role to play in detecting the progression.
Dr. Chandrasekhar, would you like to opine? And because what we have seen is many a times people in practice sometimes actually just delete doing fields altogether. They just depend totally on OCTs. Sir?
Absolutely not allowed.
Yes.
The early glaucoma, if you want to justify treatment, change or enhance treatment, change in the RNFL thickness trend over a period of time, or GCC, would probably help. Their visual fields will not show change. If the pressures are already high, if you're treating a patient already, you will enhance the treatment to get to the target pressure that you need to get to, which is a little higher in that situation. But once the defect is established in moderate glaucoma, because of the floor effect that the anatomical changes or OCT will have, you have to follow them up with visual fields. In following up with visual fields, because there are some examples from the panelists that did not have 10-2, I would stress the point that in advanced glaucoma, you need to follow both with 24-2 as well as 10-2. Just doing 24-2 alone also is not sufficient. I would spend the money on doing 10-2 rather than in imaging in a patient with advanced glaucoma.
Okay, I think that is very, very clearly brought out. And there's another question, which is a classical question, I think, which is asked every time. If you have to give a combination of PG analogs and beta blockers together, would you give it in the morning or in the night? So Rita, would you like to take that?
Yeah, there is this big debate about whether you should give this combination in the evening or in the morning. I think I prefer to give it in the morning, and I have a reason to do that. We know that the beta blockers are not really effective at night, and they have a short half-life. So if you give a beta blocker with a prostaglandin in the night, you don't get the effect of the beta blocker anyways. So if you give it in the morning, you get the action of the beta blocker in the first half, immediately after instilling the drop, and the maximum action of the prostaglandins comes to you in the night when you want it to come. And maybe when there is a diurnal rise of pressure in the early morning, you are adding the drop to flatten that rise that has happened. So I, in my own practice, believe to use prostaglandin with beta blockers in the morning. I am open to other people.
Anybody else in the panel wants to challenge this view? Or Dr. Chandrasekhar, let's get your view on this, because this question is always asked.
Let me put some perspective historically. PG analogs, initial clinical trials were done by giving them at the night. The major concern at that time was the redness that these medications would cause. So they gave it in the night so that by the time the patient gets up in the morning, the redness is taken care of. There is nothing else sacrosanct as far as the biology of the medication is concerned, that it should work better when you give it in the night than in the morning. It can be given in the morning also, even if you're giving only PG analog, based on the patient's convenience. The only comfort this thing is that because of the redness that may be there, they started using it, because all clinical trials used it in the night. We say that follow the clinical trial pattern and use it in the night. So there is no harm in using either the PG analog or the combination medicine in the morning. Having said that, about the beta blocker activity not being there in the night and being risky and so on and so forth, that's a theoretical consideration, may not be applicable to all patients. We keep seeing patients who miss the night dose and come in the morning where their intraocular pressures are not controlled when you use beta blocker twice a day. So those patients who are at risk of losing vision because of the systemic vascular factors, do you want to give a beta blocker at all? And do you want to give the beta blocker in the night? Are they getting a beta blocker, the systemic medication? The antihypertensive nowadays are also single dose therapy, they give only in the morning. So I don't think there is anything sacrosanct, they can be given in the morning.
Okay, I think that's pretty much clarifies. You give it at the time. So would you like to do a diurnal variation check where the peak is and place the PG analog around 10 hours before that? That is where the peak comes, or
that is a worthwhile thing to do in cases who are progressing with office pressures.
yeah, if suppose the thing is coming in the morning, the peaks are coming in the morning, would you then prefer that we give it in the night and split them up rather than give a combination?
Which is fair to do. What I'm saying is that so in the cases where you do a diurnal and you have that information, you can time it accordingly.
Okay.
One of the other things that we need to do is probably if you're giving a PG analog, if you can check the pressure before the drop is put next time. Whether the trough also is getting covered or not is what we will see.
Okay. Okay, that pretty much clarifies this thing. And I think, sir, we are, as far as the questions asked by people are concerned, we are pretty much through. So any panel person wants to ask anything to the colleagues, there's one small thing, Manish, Dr. Manish Singh. I think we have two Manishs here. So Dr. Manish Singh, just a little observation that in the second case you had shown this, and then you had, though there was a clear this thing, vertical cutoff on one of the fields, but you just demonstrated that you did the first number of vascular tests. And I was just wondering, because actually in practice the vascular tests are costing quite a bit. So I was wondering if you have a clear thing which is making you feel that maybe there's something in the brain causing a tumor or something. Would you first go for MRI, or would you give it the way it is? Manish?
Yes, sir. So I think I'll agree with you. Looking at the field, it was very much looking like neurological. So in this case, MRI will be the first investigation. In this particular patient, since patient was diabetic and there were other health issues, so we did a carotid Doppler also. Although in this particular case, MRI will be the preferred investigation. I also mentioned a few tests to sort of as a part of discussion that what other things we can do in these.
Yeah, exactly. That's what I was thinking, because you are just filling the whole thing.
Exactly. Just to highlight these things can be done.
But I think we
MRI
have to,
definitely is the
because we have to highlight to people also, because what I'm seeing is that a lot of youngsters will just write 10 tests and not even bother. As a matter of fact, you have to go step by step, because every test is costing hell of a lot. And so they have to be careful about that. Satyan, anything you have to add?
No, I'm just waiting for you to complete the panel discussion so that we can show the answers and the winners.
Yeah, please.
So one small thing I would like to highlight based on these cases. In the cases where there is ischemic optic neuropathy or some other nerve pathology, along with glaucoma in the differential, I think one of the clinical things that we need to remember, which we don't often do enough, is probably do a color vision.
Oh, yes. Yes. I think that is very critical. It's a simple test like that.
Color vision and apparent pupillary defect is something that we need to carefully pay attention to.
Right.
The second thing is, as far as PG analogs is concerned, to decide whether they are effective or not, we may have to wait for 4 to 6 weeks before adding another medication or saying that this is not effective. Because some of the presentations were talking about PG analogs. There is no point in shifting medication before giving it the full peak effect that can come. That's the other thing that I had made notes I wanted to mention.
And sir, how often would you like to switch it from one brand of PG analog to other things?
Not very often, but it does work. Because they're biologically different compounds, it does work.
So the message we have to pass on is that first we will like to switch between brands, and then only we will. Not the brands, I mean to say, sorry, the different PG analogs.
If the response is close to 0, there is no point in switching.
Okay.
Because 10 to 15 to 20% of glaucoma eyes do not respond to PG analogs.
Okay.
Depending on the amount of damage that is present there, you can't keep fooling around with the change of medications. You need to go on to the next step when it is required in the patients with advanced glaucoma. That's something that you need to remember.
Okay.
One more point, once again, about Manish's presentation is that optic disc pit can be a congenital anomaly. I think he pointed that also, but they can be acquired due to glaucoma also. So just because there is a pit, we cannot take it that it is only congenital. Localized notches in glaucoma, especially normal tension glaucoma, can present just like pits. And one needs to be careful in deciding that they are acquired, they are congenital and not acquired. That needs to be kept in mind.
Right, sir.
Okay, over to you, Satyan.
Thank you, sir. Thank you so much for a lot of very practical tips for the practice management. So can you just show the answer slides for the quiz?
Hello. I think I screen share.
Yeah,
Okay,
yeah,
yes.
please. So go to the answers. Next slide. So you can see the first question answer is the retrobulbar vessels for the color Doppler imaging measures. Is the retrobulbar vessels is the one which we look at. Next one. The increase in the ocular blood flow is seen most in the carbonic anhydrase inhibitors. So CIPLA people purposefully put this particular slide. It's not from CIPLA, sorry. It is from Murli Ariga. Next one. The third one is from Dr. Manish. He has put it as a stereoscopic disc evaluation with the high plus lenses is the answer for the third question on the optic disc in glaucoma. Next question. Next answer, 4. And the most important finding indicating the non-glaucomatous is the optic disc pallor. Again, this question has come from Dr. Manish. Next slide. What are the vascular risk factors? This is the question from Dr. Sunita. She has said that it is all of the above, that is diabetes, migraine, and others. Question number 6. The first line is PG analog for this question 6. Dr. Sunita Dubey. Next slide. And for the question number 7, which is a long one from Harsha, always Harsha wants to put it a little complicated. The answer is D. Both visual fields and imaging methods suffer from similar levels of problems. So
that is wrong. So we need to remember that this is a negative question.
Yeah, that is a negative question. So people, that's why I repeatedly said not true.
Yeah.
I hope many of you have just understood that. The question number 8 is again, what is not true is the question. In advanced glaucoma, the answer is in the multiple choice is C. Again, this question has come from Dr. Harsha Rao. Question number 9 is on the percentage of exfoliation. That is, answer is C, 40 to 60%. That is, question is from Dr. Pandau. And on question number 10, which of the phenotypes is for the faster progression is exfoliation syndrome. Next question. Question number 11. This is what I was telling you. If you have just listened to every speaker, you would have got all the answers. Question number 11, the genes is LOXL1. Next question. Question number 12 is from Dr. Manish. OSD in glaucoma patients, which of the following is not likely to contribute is the MMC surgery in glaucoma surgery, used in glaucoma surgery. Yeah, next question. 13, the patient with the angle closure post PI, 1 PI done, and the answer is B, that is a trap with MMC. Question number 14, this is from Dr. Roni George. All of the following can be used to treat the conjunctival leak except the compression suture. Yes, last question. And the autologous blood injections can be used in all except the encysted lips. So thank you all for answering your questions. Pooja will have the winners, and Dr. DC sir will announce the winners. DC sir, over to you, sir.
Congratulations to Alka Pandey, first prize for the quiz at Envision. Pooja, do you know where she's from or whatever, some details about?
Sir, we'll get the details later on from the
Okay.
backend.
Congratulations to Alka.
We'll be contacting them, sir.
Okay, congratulations to Alka. Next one. Oh, Shruti. Second prize goes to Dr. Shruti. Congratulations, Dr. Shruti. Congratulations to both of you. There is no tie. There are, with this kind of a quiz with all the answers given ahead of time, I would have suspected there should have been many ties.
No, sir.
No,
sir.
no
So
manipulation.
it was a tie between the first and the second winner, but both answered 14 questions correctly. But Dr. Alka answered faster. So.
Okay, that's good to hear. Congratulations to both of you. Over to Pooja for vote of thanks now, before people faint.
Dear distinguished guests, as we come to the end of this 2-day Envision conference, on behalf of Cipla Limited, I would like to thank all our distinguished faculty, the chairpersons, moderators, panelists, as well as speakers for their valuable time and contribution, making this conference a grand success. I would also like to thank our audience who took out their valuable time and attended this unique 2-day virtual conference. We hope that the knowledge gained from Envision 2020 would be useful to you in your day-to-day clinical practice. Request all of you to fill out the feedback forms which you will soon receive on your registered email ID, which will help us to implement relevant amendments to future such scientific programs. I would also like to thank AIOS for collaborating with Cipla for Envision not only this year but last year too, and hoping to continue this collaboration in future. And a special thanks to Dr. Lalit Verma for his guidance and contribution for bringing the entire event together. We assure you that we will plan many more such interactive meetings and upcoming trends in ophthalmology in future too. Till then, take care, stay safe, and here's wishing everyone a happy World Sight Day in advance. Thank you very much.